And we also are proud to welcome our additional CEO, Dr. Praveen Gedam sir, and the financial advisor NHA, Mr. G.U. Ahmed sir, and my colleague, Dr. Sudha Chandrasekhar, the Executive Director of Health Policy and Hospital Engagement. This is a function which we wanted to organize since quite some time, kind of a platform for knowledge sharing across the National Health Authority and the state health agencies, and we couldn't have had a better timing of this event when we also are having a side event where participants from 13 JLN countries have come together to write a manual on the revision of health benefits package. So without any further ado, I'd hand over to my colleague, Dr. Sudha, to please come over and begin the proceedings of this workshop. Thank you very much.
Good morning to one and all. It's a great pleasure to welcome you all. We are identified as a critical topic for National Health Authority, the PMJY scheme. So optimizing and updating the health benefit packages for universal health coverage. So we have amongst us all the dignitaries and representative from all the states and union territories, represent health benefit packages, and all our development partners here. So we want to welcome everyone, and I hope this will be a very good learning and sharing session to understand how we can improve preparing and designing the health benefit packages much better. So without any delay, I would like to request Dr. Praveen Gedam, Additional CEO, National Health Authority, to set the context for this workshop.
Thanks, Dr. Sudha. Dr. Vinod Paul, Member Niti Aayog, Dr. Sharma, CEO NHA, Mr. Ahmed, Financial Advisor, Dr. Rodrigue Coffrin, WHO's Country Director, Sheena and Mr. Somil from the World Bank, Mr. Pete from Center for Global Development, all the representatives from various partners, multilateral organizations, research and academic institutions, state governments and UTs. I extend a warm welcome to all of you on behalf of the National Health Authority. We are completing almost 4 years of the very important, prestigious and flagship health insurance scheme of the Government of India, that is Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. When we talk about provision of healthcare, I can think of two broad aspects. One is how is the quality of healthcare, which depends on infrastructure, HR, SOPs and so on and so forth. But second and often neglected part, even in I am a doctor and even in the medical curriculum, is about access to healthcare. And one of the key components of providing access to ensure financial access. How do you reduce the out-of-pocket expenditure? How do you prevent catastrophic expenditure and thereby prevent people from going below the poverty line? And when we think in Indian context about providing payment or provider payment mechanism, the typical well understood concept is as follows. You go to a GP or a doctor, you pay his fees, then you go to a pharmacy, you pay to pharmacy, you go to laboratory, pay to the laboratory, and so on and so forth, which is what is known as kind of fee for service in a technical terms. But when we talk about providing healthcare to thousands, millions or billions, this apparently simplistic model becomes very difficult to implement because of practicality. How do you actually calculate 1 million claims in this way per month? So the capacities get overwhelmed. And that's why when this PMJY was launched in the year 2018, we went for a model which is slightly less complex, more practical, that we call health benefit packages. But again, there are issues with HBPs. Ideally, if you think of a medical science or providing healthcare, its number of ailments and the complexities and compounding factors, they are actually probably innumerable. So how do you define rates for each and every disease with different levels of severity, with involvement of different organs to different extent, considering the age, gender and such other factors and comorbidities? So the practical golden mean, if I can say so, that was decided that let us have a few hundred identified disease categories which we call health benefit packages, and let us decide rates for that. Initially, while launching the scheme, it was done in a kind of quick and dirty manner because scheme was to be launched, and later on they were slightly fine-tuned with the help of experts. But even now, we still have around 1600 packages, and everybody is aware that number of diseases are not limited to 1600. So how do we ensure that things are fine-tuned even further? And that's how we started discussing DRGs in the NHA. And I'm happy to share that this journey from fee for service to HBP to DRG, at least talking about DRG is implementing pilot 4 years in a country as large, diverse and complex as India. But this is just a simplistic, generalized overview. We are here, we right now are having a gathering, 2-day conference where practitioners and researchers and experts are meeting together and discussing these issues. It is very important for practitioners, that is state governments and union territories, to understand the nuances and complexities of what goes in the provider payment mechanism, so that our PMJY and all the allied schemes, they are even fine-tuned in a better way. And while doing so, we have to ensure that the provider is not feeling that this looks like a bit too complex or difficult to understand, and whether I will be actually getting the due remuneration of what kind of healthcare I am providing. So we have to keep everything in consideration. The capacity of payer, in this case government, to pay and ensure that there is no overpay. Also the feeling of provider, so that he has a feeling that he is not getting underpaid, and at the same time the quality of treatment is to be ensured. So all these things we will be discussing today and tomorrow, and I am sure after the end of this discussion involving experts from India and from abroad, states and UT officials and of course NHA officials will go back to their offices with richer knowledge, and with hope, I hope that we will be able to implement the takeaways from this important conference to improvise our scheme even further. With this background, I once again welcome all of you and look forward to next 2 days of rich and enriching kind of discussion. Thank you so much.
Thank you, sir, for the welcome address. Now I request our CEO, sir, to give a welcome plant to our keynote speaker, Dr. Vinod Paul from NITI Aayog. I would request our additional CEO, Dr. Praveen Gedam, to welcome our CEO, sir, with a planter. I request Dr. 𝒂𝒑𝒊𝒛𝒊𝒏𝒈 to give a planter to, and our financial advisor, Dr. Ahmed sir. Yesterday, when we were having the pre-workshop event, we were discussing a lot about how designing health benefit package and the interaction with the finance department is so important to make sure that the benefit packages are actually implemented what they are designed and in a way that they need to be done. So we have amongst us today our financial advisor who helped us in ensuring that whatever we plan is well funded and well resourced. So I request our financial advisor, Dr. Ahmed sir, to speak a few words.
Good morning, respected Dr. Vinod, all, our CEO Dr. R.S. Sharma, my colleague Praveen, Dr. Shankar and Dr. Sudha. I am financial advisor to National Health Authority. So I'll confine myself to the financial aspect of this health benefit packages. Yesterday I got a file and I was struggling, being a technical subject, whether it should be called sickle cell anemia or sickle cell disease. So that was some expert committee was formed, and we'll have to agree some of these, all the aspects of this policy, this scheme. Now under this scheme, what we are doing, we are providing 5 lakh rupees cashless treatment to secondary or tertiary care to these beneficiaries. Now what is central to this 5 lakh rupees under various, either it is insurance based scheme or trust or a mix of both, that beneficiary should get the treatment, the adoption of these packages. So I hope this conference, which is rightly said knowledge conference, knowledge workshop, not conference, it's a knowledge workshop where we are, whatever we have learned so far, we'll sharing with you.
Since the very inception of it. In fact, he was the one who more or less formulated the project, gave this idea. So I think his being here is extremely important and we are very happy. And my colleagues here on the dais, Dr. Praveen Gedam, Mr. Ahmed, Dr. Sudha Chandrasekhar, Shankar Prinja, our partners from the World Bank, I see Seena Chhabra-ji, I see Offrin, Dr. Roderick Offrin, Dr. Samil Nagpal from the JLN and World Bank, and Dr. Peter Baker, Center for Global Development, our friends from the states and our friends from other countries who have come here. I must welcome you all. It is an extremely important conference and workshop, a knowledge workshop as Ahmed called it, which is going to take place, which is 2 days. And then thereafter also they will sort of update and upgrade the overall health benefit package. Yesterday also Dr. Chandrasekhar was telling me that there have been some deliberations on this issue. So I think the whole purpose of this workshop is to fine-tune the methodologies, the principles of health benefit packages. Let me also share with you, as Praveen was sharing, that initially the rates, etc., were fixed in a slightly ad hoc manner because, as always in the government, there is a hurry to start the scheme, launch the scheme, and then many things happen thereafter. It's not as if we have a huge time to deliberate on issues and then we finally come up. So initially the rates were somewhat ad hoc, but since then we have been having the health benefit package revisions, also adding certain diseases or certain interventions into that. So we had health benefit package 1 and then 2, 2.01, 2.1, 2.2, and the final one is HBP 2022, which has been released a couple of months back, and states are in the process of adoption of that sort of package. As Praveen mentioned, it is actually a scheme which is being implemented by the state governments. They are the ones, because state governments, and also we share some expenditure, but broadly the states are the ones who actually implement this scheme. Couple of things which are very impressive, and I must compliment my predecessors and other officers in this authority who from the very beginning wanted to make this scheme as a paperless scheme. Paperless in the sense that we don't want to process these bills in a physical manner. We want to have a workflow, a very well-defined workflow where things are done in a paperless manner. So while it is true that the documents which are uploaded by the hospitals who are providing treatment, they are uploaded, they are scanned documents generally, and some of them are machine readable too, discharge slip and all that. But largely they are, non-machine readable. But since then, the whole process is digital, starting from the acceptance of the bill, pre-authorization, then discharge, and then, processing them and paying them digitally to their bank account of the hospital. So I think that's something which is a very good decision which was taken, and since the very beginning this is being implemented. The result has been that we have a huge amount of data available with us relating to the interventions, the diseases, and the other kinds of things which are happening. We process about 1 million claims per month, which is a very, very significant number. And that, we must have spent about $6 billion thus far in the 4 years that we have been in existence on this scheme. It is world's largest scheme which provides insurance, health assurance to about 40% of India's bottom of the pyramid, and that becomes about 500 million people. And I don't think there is any scheme in the world which has such huge coverage. And this is the beauty of this scheme, and we are able to leverage the larger risk pool. Actually, it makes it possible that we spend less amount of money. Now, what is also happening is that the National Health Authority has been, making convergence of various other schemes also and bringing it on its information technology platform. And that is very interesting and important, because this gives again the methodology for implementing other schemes. They are learning from the PMJY, and we are able to process their claims on the platform, and again it gives us a huge amount of data. So we are basically able to figure out as to which are the diseases, what's the frequency of them, and I think what can happen and what is happening in the construction of the HBP also is that we are having a data-driven policy making. In a way, we are actually using data to implement and make policies. We make these rates. Another interesting thing which has been done by NHA, and thanks to Dr. Sudha and 𝒂𝒑𝒊𝒛𝒊𝒏𝒈, that we created a open discussion paper, a consultation paper on the principle of fixation of the rates. So that's something very interesting, and what we are saying is these overall principles. And that way what can happen is that rather than a very ad hoc mechanism, we will have a very scientific method of computing the rates of various health benefit packages. So I think that's also a very good thing which has been done in the process. We are also having the evidence on cost and cost effectiveness of interventions. So ultimate idea as the whole scheme is first of all, the overarching objective is to ensure that poor people do not go back to poverty, below poverty line after they have had a catastrophic health issue in their family. So that's why the out-of-pocket expenditure has to reduce. There have been a number of digital interventions which we have done. One is that because India has the digital identity, so the digital identity helps us in ensuring that a person, when he or she comes to the hospital, they are digitally identified, that they are the ones who they claim to be. So that's one very important part. There are other, interventions, other digital public goods which India has developed. Digital signatures on demand, for example, and many other direct benefit transfers, for example. They are being utilized. Recently, we have also started, giving money to the people for their own diagnostic related expenditures. Because essentially in a benefit package, what happens, everything is bundled together, including the diagnostics. And many times the hospitals, they just become a little more smart. And what they say, you go and get the X-ray done from outside, you go and get your blood test from outside, and then the money is paid by the beneficiary. But then that is included by them as their claim, because claims amount is fixed, because it's a bundle of multiple activities. So we have started, giving direct money on 2nd of August 2021, a concept called e-rupee. E-rupee is essentially a digital voucher given to the beneficiary, which can be used only for a specific purpose. So suppose I say that this money is for medicines, this voucher can be redeemed only at the medical, pharmacy. So that's how this whole thing ensures that the person is not able to sort of spend the money in whatever way he likes to spend. And if the, let's say, hospital is itself doing the diagnostics, then hospital can take the money after, proper accounting. So this way, what is happening is that we have ensured that the out-of-pocket expenditures are minimized and beneficiary feels absolutely empowered. The latest initiative by our Honorable Prime Minister is to ensure that every beneficiary gets some token that he is indeed the beneficiary of Ayushman Bharat PMJY. So those cards are being distributed, the plastic cards, which are very inexpensive cards, but which have the photograph of the beneficiary, his PMJY ID, and then finally what his wallet is. We have the applications, the mobile applications, wherein a family can figure out as to what is the balance in their wallet. As Ahmed said, we are giving 5 lakh rupees per family per year, and therefore as and when they spend the money or their money gets spent on their diseases, then every time this gets reduced, and then one can say as to how much is the balance in his pocket. There are other interventions also which we have done in order to ensure that the hospitals are paid in time. We have introduced a concept of green channel payments, whereby we release 50% of the claims immediately after receipt of the claims. So that's one. Secondly, if there is a disease which has more than 5 lakh worth of expenditure, or the money is less, then we have even provided a co-payment facility or facility by any other method, any other scheme, so that his money is spent. It's not as if if the claim goes beyond 5 lakhs, then nothing is paid out of PMJY. That's not the case now. So I think we continue to evolve, we continue to innovate, we continue to think ahead. And I think one of the most important intervention is the health benefit package, costing, their effectiveness, and how, because ultimately if you make them too stingy, too less, hospitals feel reluctant in providing the services. Secondly, if you make them too more, then what will happen, hospitals will provide, but ultimately the money, which is the public money, will not get well spent. So I think there are balances which have to be struck in order to ensure that we are able to have the optimal utilization of the public funds. At the same time, our patients, which are the central to this scheme, they are able to get the best deal out of the money spent. So I am sure the 2 days, today and tomorrow, which you are going to discuss on the health benefit packages, we will be able to share experiences, and I am very happy to know that there are as many as 11 countries which are participating in this workshop. I am sure we are going to learn from them, because our belief is we learn from each other, and then we don't need to reinvent the wheel. Somebody has done some best practices in his or her own country. I think that we can certainly sort of incorporate in our kind of system. So this way, I think it's going to be an extremely beneficial workshop, 2 days workshop. I wish everybody great success in learning and learning from each other, and then going back to your own country and probably thinking as to what can be done. Last area which I think Praveen Gedam referred to is the DRG. The DRG pilot we are doing in our country, and while many countries have taken years and years together to implement DRG, we probably will be able to utilize their learning and probably will be able to reduce this whole speed of implementation of DRG. But we are very cognizant of the fact that while DRG is a more scientific method of computation, there are other implementation challenges which will come in DRG, and therefore we should not hurry up. We should only be going there only when we are really ready to go. So thank you once again for inviting me, and again I welcome Dr. and I think we'll benefit from his thoughts. Thank you very much.
Thank you very much, sir. Definitely we will make sure that we'll make the best of the 2 days that we have with all the states and the other countries, so that we will ensure that the learnings are well shared and we are able to refine our processes much better. This event, we have collaborated with multiple partners to ensure that technical exchange of information and also support is given for making sure that we are all here together today. And one of the main partners is our joint learning network, and we have seen that India has been a very active contributor in this joint learning network, which is more a peer-to-peer learning approach with different countries. So I request Sheena Chabra, the Senior Health Specialist from World Bank, to share a little bit on give an introduction to the JLN and also give the remarks from the World Bank on this workshop.
Good morning, everybody. Esteemed members on the dais, Dr. Vinod Paul, Dr. R.S. Sharma, Dr. Gedam, Sri Ahmed, Dr. Sudha Chandrasekhar, Dr. Shankar Prinja, my esteemed fellow colleagues from the development partners, Dr. Rodrigo Offrin, Dr. Pete Baker, Dr. Abha Mendirata, and other esteemed participants from NHAs and all the state health agencies, and most of all, the international JLN participants from 11 countries, and if you include India, actually 12, India being one of the founding members. And I'm delighted that 9 of the JLN countries are actually physically present here. JLN, as Dr. Sudha Chandrasekhar was mentioning, is a joint learning network for universal health coverage. And just to go back to the history of JLN, actually, India has been pioneering in terms of looking at government-sponsored health insurance schemes. And prior to PMJ, you know, we had there were 20 different schemes mushrooming in India with different state-level schemes, national-level scheme with RSBY, etc. And what we used to have is a government-sponsored health insurance scheme fora where every 6 months on a topic which was relevant for the practitioners, and they were grappling with whether it was looking at capacity building, monitoring, fraud management, quality of care, etc., where the practitioners from these different countries would come in and look at what have been their experiences, what have been some of the challenges, and how to overcome those challenges, and really share experiences. And then also products that came out, you know, like we talk about the NABH standards, the entry-level standards were actually one of the quality collaboratives in the joint, the GHIS fora, which had come together to sort of really come and develop that as a product of joint learning. And looking at the experience of what it could do with that state-level learning gave birth to the joint learning network for universal health coverage, and various development partners came in to support that. and various countries participated in that. And we are really delighted that as we are looking at the optimization of health benefit packages and how do you really look at revision of the health benefit packages, in this room we have 11 countries which are present, from Bangladesh, Ethiopia, Ghana, Indonesia, Kenya, Laos, Malaysia, Mongolia, and South Africa. And we also had Nigeria and Vietnam join online as they could not physically be present. So it's really been, a proud privilege and honor for the World Bank to partner with CGD, JLN, and the WHO to provide support to NHA for this very important national workshop. Because, if you look at benefit packages, they are really the fundamental element or the heart of any health scheme. That determines what the scheme performance is going to be, what the provider behavior is going to be as they engage on a particular scheme, and also in terms of ultimately what kind of patient care is going to be provided from the scheme. And this workshop promises to be an excellent platform for exchanging India's experiences. And when I say India's experiences, really the experiences of the 33 states and the union territories that are participating in PMJ, in really looking at the optimization and updating of the health benefit packages. And also this workshop is going to help us distill the experiences of other countries to improve equity and efficiency of spending within the limited health budget that is available. In terms of World Bank in India has had long-standing experience of providing technical support in the area of health insurance in India, and has provided TA since the formative years of the Rashtriya Swasthya Bima Yojana, which was the federal predecessor scheme to PMJ, since 2008, and we have been engaged in also working on specific state-level schemes. Karnataka, I know with Dr. Sudha Chandrasekhar, who comes from Karnataka, working on health insurance schemes in Karnataka, in Meghalaya, in Uttarakhand, etc. And I've already talked about the learning platform and the practitioner-to-practitioner learning. It's really been our privilege to be a partner on PMJ at the request of the Government of India and the National Health Authority. World Bank has been engaged in providing multi-year technical support to PMJ right from its very design and inception to date. And largely, our technical support is organized around 4 thematic pillars. The very important pillar of sustainability, which focuses on the core purchasing functions of PMJ, and on top of that, where we provide technical support. The other, also very significant pillar of our support is in the area of knowledge and learning, and that's where we look at a spectacular journey. It's been very, very impressive. What has been impressive is, as Dr. Sharma alluded to, in terms of there has been a lot of openness, continuous reflection of the experience of the implementation of the packages. And there has been multiple stakeholder engagement, whether it's with the hospitals, whether be it with experts, with other partners, to look at what's working, what's not working, what's missing from the packages, how the pricing of the packages need to be looked at in terms of actually what the costs may be. And big
packages given the resources at hand. The current NHA initiative in optimizing benefit package design process and methodologies comes at an opportune time. I hope the deliberations will really be very forthright and really dig deep so that we find solutions and project on issues as early as now. As the understanding of the processes, tools, and resources available for reviewing and updating the health benefit packages evolve, I believe the states will also be well-placed or better placed to adapt the health benefit packages to suit their needs. Through efficiently leveraging evidence and process outcomes, NHA will be able to better cater to needs and ensure the maximum value on its investments. At the end of the day, it is people we think about and their health. A systematic and structured approach as being proposed by NHA is really the need of the hour. We have been involved as WHO in mapping the validation of HBP to the new and improved ICD-11 codes, capacity building on ICD-11 and ICHI, advisory on IT integration of ICD-11 and ICHI, as well as quality mechanisms for medical coding. There's also a future in terms of even coding in the next ICD, traditional medicine. The discussions globally are already happening in this, and India is also leading this. So this is another future aspect. We remain committed in supporting NHA and working collaboratively with partners to maximize comparative advantages each of us come with. Best wishes to all of you and and all the best in the deliberations. We look forward to continue working with all of you and the success of continued rollout of the health benefit package. Thanks so much.
Thank you, and I think we had a marathon engagement with WHO by the time we could roll out the ICD, ICHI, and all the members from the headquarters and the country office. There's been good support. So that was the main intention, is that, you know, we can't do this alone, and, you know, if we want to cut down the learning curve, we have to make sure that we collaborate and work with the people who are the best. So in the continuation with the, you know, the collaborators, I would request Dr. Peter Baker from the Center for Global Development, whom we look forward to a lot of technical support that we have been, you know, in preparing these workshop and also supporting the health benefit packages.
Thank you very much, colleagues. It's a real privilege and pleasure to be here and to be on the, with such esteemed members of the dais as well. So to introduce myself, my name is Dr. Peter Baker. In the UK, I sit on one of the committees in an organisation called NICE, which helps to set the equivalent of the health benefit package in the UK. But really here today, I'm representing the Centre for Global Development, which has two functions here. It's both the co-facilitator of the efficiency collaborative of the JLN, which Sheena has introduced so well, but also the secretariat of the International Decision Support Initiative. We are a network of 7 organizations working in 8 countries on exactly this kind of topic. And the most exciting and I think impressive project of all of IDSI's work has, I think, been the honor to work with our India partners. It's been over 10 years of partnership. I think it's been a really an incredible journey to watch how India has expanded the UHC coverage. You know, we just heard the 500 million people covered now under PMJ. The 3, I guess, big highlights for me have been working in partnership to see the development of HTA in India, the HTIN program, which uses a health technology assessment approach to consider what services and technologies would be really high value for India. Secondly, to work with the National Cancer Grid. I hope we've got colleagues here for NCG as well here today, to optimize cancer services in India. And thirdly, to work with the NHA and Dr. Prinja on issues related to kind of standard processes for health benefit package design in the NHA. So it's been an incredible 10 years. I'm very excited, I hope, for another 10 years of partnership with you all. I think in particular, the thing I'm most looking forward to is to think about how we use the health technology assessment approach, which is to really rigorously look at the benefits and cost effectiveness and impact of technologies, to do 3 things. Firstly, to contribute to benefit package design, but secondly, to consider what prices commodities should be priced at using the best evidence, and thirdly, to think about guidelines, what would be the optimal guidelines for high quality clinical care in India. So that's the 3 things I'm looking forward to going forward, but mostly I'm looking forward to today and to this workshop, to hearing the expertise and insights from India, but also, of course, the other 9 JLN countries here today. So I won't take up any more of your time, but thank you for the chance to introduce myself and the project, and I'm very excited to be here for the rest of today. Thank you.
Thank you. Now we will have the keynote address by Dr. Vinod Paul, member Niti Aayog, Government of India. He has been a strong supporter of National Health Authority and the PMJY scheme for a lot of policy decisions and the push that he gives to ensure they are considered and implemented.
Thank you, Sudha. Good morning. Namaste. Respected Dr. R.S. Sharma ji, Dr. Praveen Gedam, Shri Ahmed ji, Dr. Brinja, Dr. Sudha, and my very distinguished leaders of our development partners, Dr. Rodrigo, Sheena, distinguished guests and experts from 11 countries, which is amazing. Distinguished colleagues from state governments representing the entire nation, friends. Thank you very much for the opportunity, the opportunity that you have provided me today to be amongst you. PMJ has been a success. It is the flagship program of our nation. It carries the name of the Prime Minister's Jan Arogya Yojana. And as the first pillar of Ayushman Bharat, twinned with comprehensive primary health care through health and wellness centers, the original two pillars, we are very proud that we have reached a point where we are moving with confidence and we have the opportunity to refine it further. I like to say that the Ayushman Bharat family of schemes is now the larger scheme. We have Ayushman Bharat infrastructure mission, we have Ayushman Bharat digital mission, and so on. So first is to congratulate the leadership of the state governments for having made sure that PMJ is a success. And also congratulations to the leadership at NHA and the Ministry of Health for making sure that this very, very important scheme, very, very important mission is iteratively improving in its structure, in its functionality, and its reach. 36 million hospitalizations in less than 4 years. Paperless system, cashless system, and continuous evolution of ensuring that it's a scheme which is easy to implement, easy to be understood, and innovations such as the e-rupee, the green channel that you heard about, are very, very encouraging, very promising, and indeed very effective. The journey to universal health coverage, journey toward ensuring a great scheme and its building blocks, is an iterative process. But India is restless. Can we leapfrog and move from one version which is successful to another version, the next version which is even more successful? We know there are gaps. We would like to see deeper reach. We would like to see more efficiencies. We would like to see quality of care. And above all, we would like to see the smile on many more faces. And that's where we assemble today. And after perhaps missing some opportunities due to Corona, because as Shankar said, such meetings are required from time to time, not in one area that we are discussing today, but also in other areas. And I'm sure there was an issue about getting together in the wake of something which affected all our lives. So very delighted that today we have the top experts of our nation interfacing with the state teams as well as the national teams. And we're looking forward to improving the very critical pillar of this mission. Today, what Dr. Sharma did not say and Praveen did not say is, it's a bone of contention with the private sector, just to put it very frankly, because they think we are not offering health benefit package rates, reimbursements to their business paradigm, shall we say, or to their satisfaction, to be more humble. This has to be sorted out because it is holding back a huge chunk of the private sector coming into the scheme to be able to provide improved access and more infrastructure and more opportunities for care in the scheme. So we are addressing perhaps the most important issue that we would like to resolve to the satisfaction of all in a transparent manner, in a scientific manner, so that we can say with confidence and we can convince our private sector, part of the private sector, that this is the way forward. And we are making a very sincere effort to make sure that it is the tight balance that Dr. R. Sharma talked about, optimum. Package rates that are not too high and not too low, just the right balance. And you heard about the differential rates. We have now accepted differential rates depending on the location. We have health technology assessment system in our country that allows us to go through the scientific journey in a systematic way, in a transparent, responsible, accountable way. So the building blocks are there and are being addressed. What we wish to hear from you today is what is the best possible, pragmatic, balanced, practical way for us to take our journey forward. And here truly experiences of other countries are important. The theoretical paradigms that underpin such decisions and the principles that underlie are important. If DRGs is the way forward, we will take that path. We'll start small, we'll start effectively, but we will move forward. There's nothing complex that India cannot accomplish if the need arises. When we build the original packages, at that time the guiding knowledge was the various schemes being implemented by several state governments, Karnataka for example, Andhra Pradesh at that time, Tamil Nadu, very excited because those things happened in my room. So we're trying to get the best balance in the most sincere and an honest way. What is the path forward based on what you saw was already working? There were imperfections. There are imperfections in the USC journey at some point in all the nations. In fact, no USC paradigm or a program in the world could be called perfect. So we're very happy that you are here to help us. We learned from you when we launched Ayushman Bharat PMJ, a long journey of learning, years of learning, because the yearning to have a universal health coverage goes back to many decades, 5 decades, 4 decades, 3 decades, and more work and more recent work. So you have been always helpful. Partners have been our guiding force, sitting with us, adapting that knowledge from the world to our settings. So we're very grateful. And indeed, experiences of other countries is very critical for us, for this particular aspect of optimizing and updating the health benefit packages. And here, the guiding principles are important. And as Dr. R.S. Sharma said, why should we reinvent the wheel? If you have a workable solution, an equation, an approach, an algorithm, we will adapt it. We don't have to reinvent, and we, particularly in this space, there is a huge opportunity of cross-learning, and has been highlighted by very distinguished colleagues. So this is, I'm very happy it is an international workshop. I'm very happy it is a knowledge workshop, sir. And I'm very happy that we are taking this journey to be, to come out with a path which can satisfy the players of our country, academics of our country, and the governments, including state government. The state governments being here, I wish to point out an important facet for our own dialogue, which worries me. You know, we heard from the very beginning, Praveen said it very rightly, that you can have an infrastructure and services, but they may not be connected to people. By the way, we have the problem today, and that's why we are here. There is a scope for access to more services, but there is a problem of not having optimum workable health benefit package bridge to reach there. We want to bridge it. We want to make sure that this happens. But having said that, there is another facet, Dr. Sharma sir, I want to point out, which we must correct. And this is again about access. And here I like to request my state governments to please keep in mind that some of the packages that are critical for achieving our national goals, the equity goals, must not be stopped from being implemented in your states by the private sector. They must be offered to the private sector as well. And I want to give an example of neonatal care packages. Now, newborn mortality reduction is a national goal. Neonatal mortality is 70% of infant mortality, more than half of child mortality. These are all SDG goals, national goals. SDG goal included. NMR is a specific SDG goal. And I learned that several state governments deny this package to the private sector. So suddenly, you know, the access is stymied, is truncated, and that's not fair, because we do not have such a large plethora or a network of neonatal services in any state for us to say that we would not like to offer it to the private sector. So if you go back to the principle of access, please, the most sick, most vulnerable, most fragile individual in any society, in fact, entire animal kingdom, is the newborn, because that is the time when there is the highest risk of dying. No day is more risky for any animal to die than the first day of life, or the second and the third, and then so on. So my plea is that for whatever consideration or whatever logic being offered to the policy teams in the state governments, please do not exclude the health benefit package access in the under the PMJ to neonates. Open it for the private sector. If adults can have their knee replaced and, you know, cardiac stents done, a newborn baby needs 5 days of care, and there is 60 years and 90 years of life ahead. So I plead with you that ensure that you open the neonatal care packages, very well thought out, to the private sector in every state, and help achieve the national goals and the SDG goals of animal. I'm saying this to make the point that you may like to review which critical national priority packages may not have been optimally represented in the choices that you make in terms of not offering some packages in the private sector. There may be others, but I am more familiar with this one because the utilization of this package, even overall, is relatively low. So there is also a need for us to mobilize people for those packages which do relate to achieving the national goals, and they are aligned to the national priorities and to the national programs. And again, I want to say that in almost all of them, to say that everything optimally is available in optimum quantities in terms of access and infrastructure and services and quality in the public sector is really not a full fair statement to make. Above all, I request that my last message is truly to say that a strong one expectation that we have from our partners is to help us build a strong research base within the NHA. We have it, but there is a significant, further intensification of research activities we can do. I would like to see how this relationship, this partnership for having a stronger, even stronger research system within NHA for this scheme and universal health coverage in general could be embedded, and that would be a great help, because as Dr. Sharma said, our approach is scientific, our approach is data driven, our approach is to make sure that no one is left behind. And in that, having health benefit packages which are transparent, optimum, scientific, resilient, robust, visible to people, to the private sector, accepted by them, is very, very critical. And to help us in that journey, you have gathered here today. We have expectations, and we are truly grateful to you for your presence and your expertise that you would offer. And thank you very much, and thank you for giving me the opportunity to be able to face to face with you. Thank you. Jai Hind.
Thank you, sir. Definitely we will deliberate on the thoughts, especially on the neonatal packages and also on the research agenda that you are guiding us to strengthen. Documentation is very key, especially in an organization with transient teams. The tacit knowledge cannot just go away. So I request Dr. 𝒂𝒊𝒏𝒈 to give a brief on some of the documents to be released today.
Thank you very much. I think CEO sir in his opening remarks has already set the stage and mentioned about the important documentation of provider payment methods and pricing that we tried articulating in a consultation paper, which was then rolled out. Stakeholder consultations were organized, and we received a large set of feedback from different stakeholders. And a compilation of all those feedbacks is consolidated in a book that is placed in front. And may I request all the dignitaries to please open the policy document that has now been finally crafted by the National Authority on provider payment methods and pricing. May I also inform that we recently also undertook a collaborative activity to document the entire process of evolution of the health benefits packages, trying to basically articulate the entire processes that had been followed in framing those health benefit packages and the different processes that have been taken in order to update these health benefit packages. So a compilation of that is this new document that we placed here, which is the second one for the release, which is a manual on health benefits package, which is the part 1. So the part 1 is the journey of what has taken place since the evolution from HPP 1.0 to 2.0 to 2.1 to 2.2 and then to 2022. And the last chapter of this manual gives a trailer of the part 2, which we are in the process of drafting, which actually articulates a prescriptive approach of how it should be undertaken as we go forward in future. So, with the words of wisdom that we have heard from the distinguished guests here on the stage, I think I would sum up the entire learning for us to deliberate over the next 3 days in terms of 3 broad questions, okay, which I think that we need to deliberate as we move forward in the discussions from the next session onwards. The first discussion agenda is, and this is strictly restricting ourselves to the health benefits package. The first is what to buy. So which means that how do we make decisions or choices about which interventions do we include and which interventions do we exclude? That's the first very basic question that we would need to answer as we move forward. The second question would be that whom do we buy from? And again, a point coming from Professor Paul's remark about the need to have a more inclusive approach towards trying to see that whom do we purchase the care from, the public or the private sector, which packages are optimal to be regulated in terms of public provisioning, or which needs to be made open for private provisioning as well, considering all the other various caveats as well. And the third important question that we would need to deliberate is, at what price do we purchase them at? So again, that brings us to one of the central questions that we've been debating about, that how do we pay our providers, what methods do we use, and then what price do we set for ourselves? So I think these are the three broad takeaways that I have from this inaugural session, and the different points that emerged from the different speakers that gave us their wisdom of the years of wisdom. So as a token of our respect and thanks, I'll request our CEO sir to please give a token of our gratitude to the Honorable Member Health Niti Aayog. May I request the ACO sir to please facilitate our CEO sir. Dr. Sudha to kindly felicitate our ACO sir. And our FSR as well. May I also request the ACO sir and our FSR to felicitate our partners, beginning from Dr. Sheena Chavda. Shikha, you can be down. I think it's Dr. Rodrigo Offren. Dr. Pete Baker. One more. Thank you very much, everyone. And before we break for tea, we'll have a small group photograph with all the participants, because we know that sir would leave. So we'll.
We can call few tables.
Yeah.
The first 2 rows and the second 2 rows later to make some space.
Sorry. Yeah. No. So we can take off the table. Take off the table and have a.
We'll sit here.
Okay.
We can have here. We can stand here and then one.
Upstairs, kas karan?
It will be difficult.
I'll difficult. We'll have it here.
The first 2 tables. We can start. How many will? Take round 1, 2, and then. I think the first 2 the tables, first 2 rows, please. Then we can have more.
Stand behind this.
May I have everyone's attention? Please, if you could please sit down. Please get your coffee in and just make yourself comfortable. So the first technical session is going to be on the role of health benefit packages in our journey towards universal health coverage. It's important to highlight that health benefit packages are not just a list of services, but they're actually a social contract, a commitment from the government on what services will be provided to the covered population. And it makes it very important that we design benefit packages which are sustainable as coverage increases, as costs increase, and the design needs to be at the center, aligned with the goals of the scheme. For this session, I request Dr. Shankar and Dr. Sudha, if you can please come and sit on the dais. Dr. Dhananjay, request if you can please kindly introduce both of them.
Hello everyone. Both of them doesn't need much bigger introduction. They are well known to everyone in the room. But still, to say that Dr. 𝒂𝒑𝒊𝒏𝒈 is an Executive Director of National Health Authority. He is the divisional head who is looking after health benefit packages, standard treatment guidelines, health insurance, quality assurance, and then the pricing. Before joining NHA, 𝒂𝒂𝒊𝒏𝒈 sir was an professor with health economics in PGI Chandigarh, and he is a member in many technical committees in the country, like the Prime Minister's Advisory Committee on Infrastructure and Resource Utilization, and many more. And he also has a very good academic experience with PGI. We request you to be as a chair for this session, sir. And we welcome you for this session. And we have our another executive director from NHA, Dr. 𝒂𝒑𝒊𝒛𝒊𝒏𝒈 𝒂𝒏𝒅. She's a medical graduate from Bangalore, 𝒂𝒏𝒂𝒕𝒊𝒏𝒈 College, and she has done community medicine MD along with master in public health, and she has done MPhil in health economics from London. And she, before joining NHA, to say that before the initiation of PMJAY, she was the director for medical management in State Health Agency, Karnataka, and she was played a very key role in many reforms related to State Health Agency, Karnataka, including the referral gateways, or maybe convergence of many schemes in the state and all. So both are equal and eminent personalities. We request you to head the session, madam. Over to you, Abha. Thank you.
So our first session is a recorded presentation. It is presented by Ursula Gideon, and she will be talking about elements of a sustainable HPP policy. Just briefly introducing Ursula. She has got 25 years of international experience in health system policy, and is the technical coordinator of Criteria, a Latin American network disseminating knowledge about health benefit package design and explicit priority setting. She is also a non-resident fellow at the Center for Global Development. Since 2010, Ursula Gideon has been working as a consultant for the Inter-American Development Bank, and she provides technical assistance to a number of countries in Latin America. She's also authored the book, What's In and What's Out, on health benefits package design, published by the Center for Global Development.
Good morning, everyone. Thank you,
screen?
first of all, for having invited me to this workshop on this important issue of the health benefits package updating process. It is a real honor to be with you and to discuss on such an important issue. And even though I won't be able to join you in person, unfortunately, I still hope that my slides and thought might stir some interesting discussion and questions. The mere fact that India is holding this workshop today is a clear indication to me that it is fully aware that the updating of health benefits packages is really a crucial issue on the move towards universal health coverage. It is still too frequently found that countries design their health benefits package as sort of a one-time effort and see them as a sort of a shopping list, even if it's evidence-based, and then leave it unattended while it gradually will lose its legitimacy and become totally outdated. So what India is now doing, given that we're talking about PMJ's health benefits package, which is I understand the largest health insurance scheme in the world, is also important in another sense. I think that this issue hasn't been discussed enough, especially in a comprehensive way. So what India is going to do will be a guiding light for countries around the world. So as you can see on this slide, I have decided to organize my presentation around what I think are 5 key principles for sustainable health benefits package and process. And if I use the word sustainable, it is because in the end what you want your health benefits package updating process to be is sustainable over time. So what we're going to look at during the next 20 minutes are these 5 principles, elements, which are never lose sight of the role and goals of your health benefits package. So for example, it would be strange for you to have a benefits package that explicitly is meant to improve equity and access, and then you don't consider equity as a priority setting criteria. Second, think comprehensively of your health benefits package updating process, which is to say that the updating process is not only about budget impact or costing or aid, and I think there is a whole part of this workshop today dedicated to this issue. Use evidence and analytic methods along the whole process. And 4, implement good governance principles along the whole process once again, and this is really important for your updating process to be sustainable. It is not enough to use solid methods and good evidence for your health benefits package updating process to survive over time. And then finally, 5th principle, make sure you institutionalize your health benefits package updating process. So let's now start with this first of our 5 key elements for a sound health benefits package updating process, which is the importance of not losing sight of why you adopt a health benefits package in the first place. When updating a health benefits package, there is a real danger you can't see the forest for the trees. There is a danger that you might only be worried about whether technology A is better than technology B for the money you have to treat a certain disease, while forgetting about the overall role and goals of your health benefits package. A health benefits package is actually much more than an evidence-based shopping list. It is a policy tool that seeks to make sure that scarce health resources are allocated to what matters most, making the best of them in terms of their health results and equity impact. So the updating process should be aligned with these goals. For example, looking only at clinical outcomes without consideration of efficiency or equity may be inconsistent with the goals of your health benefits package. If the goal of your health benefits package is, let's say, making the best out of the money you have or reducing inequity. And the health benefits package is also a strategic purchasing tool, as it answers one of the 3 strategic purchasing decisions. And as such, it is the starting point for many other key decisions in the health system. How much will be paid, what payment mechanisms will be used for the payment of the health services included in your health benefits package, how is the quality of services included in the health benefits package to be guaranteed, and so on. So a health benefits package really plays a central and pivotal role in any health system. So what's in, deciding what's in is actually taking a lot of responsibility with regards to the health system in general. And then last but not least, and it's something that is often being forgotten, is a health benefit package is also meant to anchor rights and guarantees with regards to what services people can access to. This is particularly important given that in many places around the world, the population has been frustrated with unfulfilled promises about universal access. It is some sort of a social contract where the government makes a tangible commitment as expressed in the health benefits package on what exactly it is going to guarantee to its population. And this is really important, not only at the philosophical level, but really with regards to the updating process. So whatever you're gonna include, you have to make sure that you can actually provide it and that people can actually access, and you might even think about guarantors to make this happen in life in the real world. So number 3 of these 5 key elements is that it is really important to think about this updating process in a comprehensive way. And I have included what could be seen as 10 basic steps you need to implement for your systematic updating process. Let's say right away that the way to break up these processes and their sequencing is highly context specific, but without even looking at the 10 steps, the mere fact of drawing this updating process as a circle indicates many really relevant things. By the way, this idea of painting the HBP updating process as a circle is based on one of the chapters of the book we have written together with Amanda Glassman and Peter Smith on What's In, What's Out, which is a book that was published some years ago by CGD on health benefits package. So having a circle indicates several things. First, it indicates that there are many steps and that these steps go beyond deciding on the inclusion or exclusion of certain technologies. And actually, from what I've learned, the Indian process of updating its ABPMJ package over the last year clearly indicates that, yes, that updating health benefits package is much more than thinking about getting evidence to include new technologies into a health benefits package. Much of the discussions have been around rates and codes and language and structure and making sure the infrastructure is actually in place to be able to provide these health benefits package. So I think the first thing is to be aware that when designing your updating process, it is a good thing to think about in a comprehensive way about your health benefits package updating process. And a second issue is that for each step, however you're gonna like cut the cake and whatever number of processes you're gonna come up with, you will have to decide not only how you're gonna implement the process, but also who, when, how frequently, and what. So each step requires a special attention to answer each of these questions. Then a third message that emerges from this circle is that this is actually not a static process, but a highly dynamic process that should take place in a periodic way, probably every year, even though in many countries, as I have said at the very start of my presentations, even though as in many countries, the updating process has been rather erratic and ad hoc. A fourth message that emerges from that circle is that by only quickly looking at the titles of each of these 10 processes, as I have depicted them here, it involves a lot of stakeholders. So you have to give a lot of attention to how you're gonna manage these stakeholders, when you're going to involve them, how you're going to involve them, how you're going to avoid conflicts of interest, how you're going to make sure that it's not only the ones shouting the most that will be heard. So this is really an important aspect. And then let's just quickly mention the 10 steps, just to give you a flavor that this is actually a very broad spectrum of processes that need to be considered. One is review the basics, basically make sure that your health benefits package and content is still in line with your initial goals. Then identify potential candidates for inclusion. Select the ones you will be able to evaluate, cost them, carry out the budgetary impact analysis. These are especially issues 2 to 6. I think Andres and Dan will talk about some of them. Then deliberate, make evidence-based recommendation, make the decision, make sure that you communicate about not only what you have decided, but how you have decided about this inclusion or exclusion. Monitor what is being provided in your health benefits package, and then it starts all again. So basically these are the 10 steps, but once again, this is highly context specific, and the sequence and even the number of these steps may vary considerably across contexts. The third key element I'd like to share with you is that to have a sustainable health benefits package updating process, you should probably use analytic methods along the whole process, as opposed to using intuitive appraisals or decisions. So why is this important? And here I'd like to quote what Peter Smith says in one of the videos in this MOOC course that was launched by CGD and IDB on what's in, what's out, and prices of pharmaceuticals. And in one of these videos, Peter Smith asks us what would happen if we didn't use analytic methods in the context of a health benefits package design and updating. And he mentions 3 things that could happen. The legitimacy of the process would be highly contested. So we wouldn't think of a decision as being legitimate if it does not use the best possible evidence. And second, if there were no analytic methods, there would be a real risk that equity would be put into danger, since the ones shouting the loudest would be the ones who would have their voices being heard. So inclusions would be aligned with power and not with need. And then last but not least, of course, if you don't use analytic methods, it is really hard to understand the consequences of the decisions you're making. So with regards to analytic methods, more specifically in the context of the 10 processes of the health benefits package updating process, we have looked at in an earlier slide. We could actually play like some sort of a drag and drop game, and we would quickly find that most of these processes can be linked to analytic quantitative or qualitative methods. So we could link, there would be on the method side issues such as cost effectiveness thresholds, budgetary impact analysis, costing methods, indicators, the design of indicators to measure values, indicators of effective coverage, HTA, budgetary impact thresholds, focus groups, and many others. And we could now link this list of methods and one you might have in your head to one of the 10 steps. So I understand that you will talk more about these methods later on today, but the key message is make sure you use them along the whole process. So our fourth key element of a sound health benefits package updating policy is related to the importance of implementing good governance principles along, again, the whole process. I will mention 3 of these good governance principles, even though different authors use different ways of grouping these principles, but I will be using the categories we used in our book, What's Up, which are transparency, participation, and coherence. And even though you will have a session on good governance and institutionalization, I think tomorrow, let me just share with you some thoughts on each of these principles. Transparency as opposed to opacity. I think it's important to keep in mind that it is not only about communicating results, but also processes and making sure the rights that ensue from your decisions. Also, being transparent means to communicate in a way that will be accessible for the target population. So really complex reports won't help to make the processes as being perceived as being transparent for a large part of the population. Then on participation, I think that there are several issues that are worth highlighting. There is always a risk of imbalance of power and skills with regards to participation. So, for example, patient advocacy groups versus lay citizens and defendants of Cinderella, what I call Cinderella issues. You have to make sure that everyone gets a voice, otherwise participation will be a way of giving more voice to the most powerful ones. Second issue I'd like to share with you on participation is don't think about participation just as a way of validating your pro forma participation, validating the results. Think that participation can really improve your decisions. Evidence won't show it all, so it will enrich your decisions besides making them more sustainable. Participation is a really complex issue. It occurs in most steps, and it is important to make sure you explicitly define who is going to participate, how and when. So this is part of institutionalization. And participation is there's no free lunch, so it's costly, can be costly, and there are trade-offs to be taken into account in terms of the level of participation and depth of participation versus the need of quickly deciding something. So it requires a lot of thinking about when and how. And then last, with regards to coherence as opposed to arbitrary changes in your updating process, there are things such as rules, guidelines, normative frameworks, manuals, standardized formats, and all these kind of documents help to introduce coherence besides having just a systematic, periodic, and process will in itself help the updating process to be coherent. And one last thing with regards to coherence, coherence with the goals of your health benefits package is actually something really important. And overall, implementing good governance processes cannot be improvised. It can be costly, and there are trade-offs that need to be considered. So now we are going to our fifth and last key elements of a sustainable health benefits package updating process, which refers to the importance that the health benefits package updating process, its steps, processes, and methods we have been talking about should be institutionalized. But what does it mean to institutionalize a health benefits package updating process? And to explain what this means, I'd like to refer to whom I think are the fathers of neo-institutionalism, March and Olson, which say that institutionalization refers to, as we can see on the slide, a relatively enduring collection of rules and organized practices that are embedded in structures of resources that are relatively invariant in the face of turnover of individuals and resilient to idiosyncratic preferences and expectations of individuals in changing external circumstances. This sentence by March and Olson allows us both to highlight what it is to institutionalize, but also to understand why it's so important. So there are some words I have highlighted on the slide. The enduring collection, so institutionalization is about making sure that practices are repeated over time. To do so, you have to put those processes into explicit rules and organized practices. So it's not only about writing down explicitly how you're going to do it, it's also doing it in reality in an organized way, in a periodic way. To be successful, these practices and explicit rules need to be embedded in structures of research, so it's not enough just to think about rules and repeat practices, but you also have to have the resource, the human resources, the financial resources, the institutional resources to make it all happen. And why do we all this? Because we want this updating process to be invariant, okay, but we want them to be invariant in the face when people change, invariant in the face of turnover of individuals, and also resilient to idiosyncratic, specific preferences of a few in order to protect the interest of the whole. So I think this very nicely says that when we institutionalize a health benefits package updating process, we protect the principles, processes, methods, and thought from particular interest. So institutionalization is the fifth principle and last principle I would like to share with you. And now I'd like to share with you one last thought before leaving this virtual space. And it is that a health benefits package can not only be seen as this abstract circle that has accompanied us along this presentation, but also a spiral, which indicates that what it is important is not so much whether to get it right in the first round, but rather think of this as an ongoing learning process where each new round is an opportunity of learning and improvement. And I sincerely think that India, with its ABBMJ updating process, is firmly installed precisely in this circle. And I would like to leave you with the quote you have on your screens by one of my favorite authors, Hermann Hesse, and I wish you 2 enlightening days in this workshop. Let me just read the quote. We have learned so much. There still remains much to learn. We are not going in circles, we are going upwards. The path is a spiral. We have already climbed many steps. That's from Hermann Hesse, 𝒂𝒕𝒊𝒚, and now thank you again for having invited me to this workshop, and hope to see you someday in the future. Bye.
Thank you very much. I think that we can have a few minutes of reflection and maybe some questions from the audience so that there is greater engagement. We definitely want this to be a more participatory event, and you being able to ask all kinds of clarifications, questions, etc. Before I open it up, I think there were three main important messages that that Ursula tried to give. One was around trying to institutionalize methods, have methods that are put in place and some criteria that are identified based on which we make these choices about health benefits packages. And the reason that she gave was very clear, that it is like, when we were in our medical schools, it used to be at some point in time that there used to come a senior professor and he used to say, in my experience, this is how it should be. So then the role of power starts to come in, and the one who has the highest power and authority is able to prevail in any such discussion. So if we have explicit methods and explicit criteria based on which we make these judgments of what to include, what not to include, it makes the process easier. The second message that she clearly gave was having transparent and participatory governance principles. Again, I do understand a lot of states also, and at the national level, we also try and institutionalize these processes of setting up these committees where we have people coming from the clinical specialty backgrounds, hospital providers. We keep continue to have these dialogues and have greater participation and information from them. And the third important message that she tried giving was to ultimately institutionalize all of this, so that it doesn't get lost in the actions of one or two individuals, but it becomes institutionalized so that whosoever is there is able to follow the same standard set of principles and methods. So those are the three main key I think takeaways from her talk. And I'll stop at this to invite any questions, comments, clarifications. So maybe we can have a mic that could be circulated. If somebody wants to, you can just please raise your hand. We'll have a mic placed at your table. I'm sure within the states we have a lot of experience and a lot of, yes, we have somebody there, from Chhattisgarh, at the back.
So thank you so much for this informative session. Myself, Dr. 𝒂𝒕𝒊𝒏𝒈 from WHO, Health Financing Consultant. So I want to understand more about the participation. So one of the slides mentioned about real participation, and though participation should be encouraged more and it's an ideal practice, it is quite often seen that participation also leads to the expectations of various stakeholders, and sometimes it's not possible to match those expectations or to incorporate those expectations of various stakeholders. So like for example, private hospitals expecting some rates which are feasible to them under the scheme. So I just want to understand your point of view on this.
I think that's an excellent point, and something that Ursula also mentioned in her talk, that when you have participation, then you also have a lot of ability to manage at some points the conflicts of interest, and also at some point to manage the extent of expectations that you raise. But I think that the purpose of having participation is also to ensure that there is greater acceptance of the entire process, and the more is there a greater acceptance, then this is going to be better accepted by individuals as well. Now here the importance of the clear criteria becomes paramount. So for example, you might have a consultation on, let's say, introduction of you were giving an option and having a discussion on which new anti-cancer drugs perhaps we could include as chemotherapy options for patients who are suffering from cancer. Now, when you have a consultation and you have private sector also coming in, I'm sure that you will get a lot new molecules, new therapies that may offer a few months additional survival at very high cost. Now, if you have a clear criteria that we are going to accept only those new molecules that are that offer a certain level of cost effectiveness, that means they offer a certain level of gain in survival or a gain in quality of life with a given level of cost. I think that's where you make your entire participation possible without necessarily contradicting their expectations as well. So in our experience, we've had a number of different stakeholders coming in and giving requests for different entities. We'll talk about that in one of our subsequent sessions also. One of the drugs that I definitely clearly remember and I can illustrate is a drug called palbociclib and ribociclib. So we got a dossier from the manufacturer saying that this is something that is very useful. We got that assessment done, and based on the findings, when we communicated back, it was very much acceptable to the clinicians also, and to the industry partner who was recommending the introduction of that particular entity. So I think having the criteria in place to begin with sorts a lot of problems of managing the stakeholders as well subsequently. Any comment, feedback from, we have other country representations as well, so if anybody would like to share from their experience. We need a mic here.
We say that we have to institutionalize it.
No, it's working. It's working. It's working. You can just keep it closer to the.
Okay. When we say that we have to institutionalize this HBP, like other thing we have in NHA, but what I have observed in SHA, we do have the process of identifying how we have to develop HBP. I think it's like institutionalized, but we may have not documented that how we are doing. Are we saying that we have to document and fix the things how we have to reach to this HBP? Institutionalization means what? We will take the committee members and how we reach what processes are like data analytics, you have said. What data analytics, what we do, we use your historic data and we do the impact of that. If you raise the rate, what will be impact in our budget? That we already do, but only thing we have not yet made it in one document, that if I leave that organization some or the other day, maybe the other person will come and he will do say, okay, I am saying that this particular procedure has to be increased. Even I have seen in this HBP 1.0 and 2.0, suddenly the rate of hemorrhoid surgery is very high, but the rest of the procedure which are of high-end procedure, it was not so. So maybe that institutionalization was lacking at that time even. So is it like we are saying that?
So I think to say that what institutionalization would clearly mean would be that at least we have the rules of business set in very clearly. That what is the process that we would be following, what would be the kind of criteria that we would be following. It eventually, if it becomes documented in some form, it is all better. But I'm sure that as in governments, we also understand the importance of having clear government orders, clear set of instructions or formulation of the necessary committees. I think those are all as well the building blocks of the institutionalization process. The development of a document may be the kind of a very long-term outcome that we may like to have, but I think that a lot of the other things that we do at the state level, such as issuing the necessary government orders for setting these committees, having clear rules articulated in terms of what would be the criteria that these members would be using in order to make choices, etc. I think those are equally as important for the institutional framework. You want to add
Yes,
something?
we have done that way also. We have used government orders, like we have inclusion and exclusion criteria, and what basis we will be reserving procedures for government hospitals. That we have done. The only thing I think it is not very systematic in our state. We have not said that we have done all these things when we have followed all these processes. If you see that, it looks like we have made a HBP, but we have used all these processes. We have released order, and even from the ministry, they have attended our workshops. Even Dr. Sudha madam also have attended. We have all done. Only thing I think we have not made it very systematic, and we have not written how we reach to this HBP 2.0.
Just wanted to add that, how you communicate the processes is also important. One is setting up the processes, but also communicating to the stakeholders that this is how we are going to do it, so that they will not question you how you have done or why you have done something, right? So it's important that that kind of a communication is provided to the key stakeholders, both the, hospitals, clinicians, so that they are aware that, and they will not question your processes. So try to make sure that you can document and also communicate the same thing.
Yes, ma'am. One last question. And then
Hello?
Yes, ma'am.
Sir, in this continuation in this question itself, sir, I am asking what are the exactly role and responsibility of NHA and SHA separately in the PMJY specific HBP?
I'll cover that in my session, so you will have better clarity on that.
So let's then move on to the next talk. I'll invite Dr. Sudha Chandrasekhar to deliver her talk. Thank you very much.
So good afternoon, and continuing with what we have been sharing, especially from the PMJY perspective, it is important to actually set the stage for clearly communicating the processes that we follow, like just to ensure that the states are aware exactly how we do it, and this is also for the other international participants to understand a little bit background about our scheme and how we have, I think all the speakers in the morning were telling we already have 4 revisions, right? So in 4 years. So in that sense, what were the criteria for each of these revisions and what were the process and how we have evolved over time is also important, because we have a commitment. India is also has committed for the SDG goal for universal health coverage. So we need to also see how PMJY and NHA contribute in terms of achieving to these goals. So I'll try to cover a little bit on our UHC goals and ideas, and also the processes of our HPP and the way forward. And some of the details will be definitely dealt in individual sessions, but I'll try to give an overview of most of the things that we do. So, and PMJY has a very big role because it is one of the flagship scheme which is ensuring financial risk protection to a large population, almost 40%. So if you look at that, we do understand that UHC is something that, we want to make sure that everyone have access to healthcare services when they need it, where they need it, and without financial hardships. So this is something that we keep thinking about it, and even states have started thinking about it. I think I have many states here who are moving. If I would just ask you to raise your hand, who are the states, if at least one hand per state, so that who are the states who are moving or planning to move towards UHC. I would say that, many states have already taken the steps, and there are many more who are going to follow in that. So we definitely need to get ourselves clear on what is this and how we are going to achieve this most important SDG goal. Because it is not only just coverage of essential health services, but also with financial risk protection. These are 2 things. Expanding access is one part of UHC, but ensuring there is no financial hardship. So that these are the goals with which even PMJY started, was mainly to ensure that we don't have much out-of-pocket expenditure for our beneficiaries. We all know India is not a simple country. So I think the WHO also said there's alag-alag programs in different states. We do have alag-alag central programs, lot of state schemes, multiple things that are happening, many people trying to cover different population groups. But again, there is a lot of overlap between the beneficiaries of these different schemes. And our surveys have said that, you know, more than 63% of the total health expenditure in India is out of pocket. So that means that, you know, we need a very strong and a large scheme to ensure that these reductions we can achieve the goal. And majority of our schemes we have both at the central level. We are trying to do that. CGHS is now running on RIT platform with their guidelines. ESIC, we are trying to see how we can share our empaneled hospital network between schemes. So we do have the other NHM and GOI overlaps that we are trying to see how we can converge on those aspects. So there are multiple things, and states have taken a lot of efforts to make sure that the state government employee schemes, there's a lot of state funded schemes, how do they converge and make sure that we populate this cube as much as possible so that we can move towards a much more unified scheme which will be easier to administer and implement. So what this PMJY is doing is trying to fill that gap, which was quite a large gap. At least to the 40% of the population, 10.74 crore families with up to 5 lakh coverage every year with inpatient services, both in the public and the private hospitals. So currently we have over 22,000 hospitals which are active and which are actually supporting the implementation of the scheme. So we have 33 states and UTs implementing the scheme, 3.4 crore hospital admissions as I speak, and 13.9 crore beneficiaries currently with a card and with who have the complete entitlement, who are aware that they have these things. So I would, you know, we are implementing these schemes both in the trust mode, insurance mode, hybrid mode, and there are 3 states who are not implementing. So again, I would ask for a show of hands, trust mode, 1 per state. So we do have a lot of states. Insurance mode, mostly the northeastern states. Hybrid mode, we have a couple of states who are working with hybrid mode. And there are 3 states like Delhi, Odisha and West Bengal who are not implementing the scheme, but they have a state-specific scheme. Definitely they are covering the beneficiaries in a different way. So you had said, what is the role of NHA? Definitely we have a very strong role, and we can make a big difference because of the kind of the negotiating power that we have. So whether it is in terms of the strategic purchasing, ensuring awareness and empowerment, technical assistance and capacity building of SHAs. There were many states who were implementing schemes before, but there were many new states who are like what we call them the greenfield states, who did not have a very strong previous experience of implementing insurance programs or any kind of government funded programs. So we have a role to ensure that the guidelines are there so that they can easily adopt and implement. And IT system is a backbone of the scheme, which many states are using. And we have also learned from the other states. I think we have the Telangana team here. So we have almost adopted their IT system. So when we were doing the PMJY, we didn't think that we had to create everything new. As our CEO was telling, that we were leveraging what is already happening in different states. So the IT system is something that we adopted. A lot of guidelines which many states had created, we have tried to adopt that. And processes to manage the hospitals in terms of ensuring how the contracts, what our MOUs are there with the hospitals, and what are the kinds of deviations, what are the actions to be taken during deviations, any kind of fraud, how to handle that. So setting up national fraud units and anti-fraud units and state level anti-fraud units to support, because this is a scheme using public money, so we need to make sure that we have strong monitoring systems to ensure that there is no misuse of these funds which are meant for specific population. As time has moved, we have been trying to add additional services, additional population, and making sure that the scheme uptake is has an upward trend. We are also trying to see how we can strengthen our existing programs, looking at how the convergence at the state level can happen, how we can add additional beneficiaries like the APL population who can actually pay. So there are examples at state level. We have Karnataka where there is a co-payment system. The Dadar Nagar Haveli, J&K is already moving towards UHC. And also we are looking at a lot of improvements within the scheme itself. I think most of you I might have met during our standard treatment protocol workshops that we have tried to, expand to all the states and making sure that those are a part of the IT system and claim processing and approvals. So we have now released all the SDGs which help in processing for all the packages that we have, the national masters. And especially we are using a lot of AI and machine learning for streamlining the system. So whether it's BIS approvals, fraud analytics, and real-time monitoring, we are able to ensure that we can give you alerts, triggers to the states on a real-time basis and to ask for reviewing these. So we are also looking at convergence of schemes. We have the construction worker schemes from the Labor Department who have been added, and we are reviewing it in few pilot states. CGHS scheme, the central government health schemes, and the CAPF schemes for the Jawans has been integrated on the IT platform. We are working with ESIC, the RAN scheme, the Rashtriya Arogya Nidhi, which is more add-on support services from the health minister's discretionary grant funds. So these are two additional schemes that are already integrated with the IT platforms. So one thing we are also looking at, which is very critical, is the continuum of care. So we have two pillars. So Ayushman Bharat, PMJY is one pillar, whereas we have the Ayushman Bharat Health and Wellness Centers, which is a very strong pillar for the primary healthcare aspect. So what we are trying to do is to ensure there is much interlinkages between these two pillars, and we have to make sure that the operationalization of this is initiated in a very structured manner. We have got the recent approval from the GB also to have a coordination committee and ensure that we work closely with both the pillars, the NHM at the state level and at the central level, and work with the wellness centers, and to see how we can have especially a common identity to track the patient's journey across the care pathway. So with this scheme which has been launched is to make sure that no one is left behind, and we have to keep on making sure that we have a comprehensive health services that are developed. So as you see that HPP has to evolve, so, and also the funding for it. So we can't have all the services from the initiation of this scheme. So we have been expanding the scope of services over time and making sure that, we link both the primary care, the daily ambulatory care services, and also see how we can integrate us with the inpatient systems. So I'll skip this. So as of now, we are still dependent on the database of 2011, but we are still trying to see how we can add more beneficiaries into the scheme. And this we have now initiated a massive card drive so that the states can confirm the beneficiaries who can be part of this scheme, and the targeted beneficiary base can be saturated. So with regard to the health benefit packages, we are still covering only inpatient services, though there are a lot of requests even from the states to cover some daycare packages and also some OPD packages, but states are doing it. For example, Meghalaya has already initiated some primary healthcare packages that could be included, but the state is bearing the funding for that. So in that sense, what we are trying to do is to make sure that whatever under the scheme, we'll make it comprehensive to cover all the expenses during that admission time, so that there is nothing out of pocket that needs to be paid by the beneficiaries, including all the registration, bed charges, and all the pre and the post hospital expenditure up to 15 days. So we have been having different versions. The latest one is the 2022, but we have been moving ahead in this journey and ensuring that there is, as we said, still many states are in different stages of implementation of these HPPs. So that is something we wanted to make sure that in the 2022 version, once 2022 versions come into force, most of the states will be at least on a common platform, because that is the minimum that all the states have to implement. Beyond that, they can add or delete few, they can add few things, but at least a basic minimum set as per the national master is available for every beneficiary. So we don't want beneficiaries to be having different scope of services in different states. So we have moved from 13,093 procedures to 1949 procedures as of now. So it's a gradual increase, but it has been a very rapid increase from 2018 to 2022. So one of the things that we also feel is that we should have a proper rationale. I think that is something that was coming up from the Ursula's presentation also, is when we do revise, we should have a proper rationale on why we are doing this and what is the process that we follow in terms of looking at how the previous schemes packages we had used. So the first one, as even Sir was saying, the first one we did it quick and dirty. So we had something from the states and we tried to make a kind of a comprehensive package with what was available and with the funding commitments that were possible. But as we moved, even then, even in the first one, we had some kind of a process which we have tried to document it, so that there are 13 subgroup specialty expert committee. There was a peer review by Niti Aayog, and then we had rationalization and rate finalization. So there was some kind of a crude process, but still we ensured that there is a process that we are trying to set up so that we can improve on that. So initially we had 1,393 packages across the specialities, and we also made sure that there was one unspecified surgical package which could be kind of the joker in the pack, because we were not sure of what we have left out and what could be very important. So we had that joker so that we could ensure that if somebody is not denied treatment for something that just because we didn't realize that that needed to be there. So at least with specific guidelines, that joker was added. So definitely there was a lot of limitations in the first. There were inconsistent terminologies, and there were a few conditions itself that were not covered, and we also looked at a bundled package amount without any kind of a split between the implant cost and any stratification. So we tried to review all these shortcomings so that in the next revision which we did, we tried to see that what is the package rates offered, which especially whether was it adequate or inadequate. So we tried to gather some feedbacks from the stakeholders, looked at any kind of inconsistency, terminology, duplications, overlapping with national health programs and high-end drugs and certain treatments. So we looked at the whole package with a new eye, with taking some specific time limit for doing this. And we took an official mandate from our governing board, from the National Health Authority, and ensured that we co-opted the expert committees what was developed from the ICMR. So, so that was done for every specialty. Actually, that gave us a lead edge, because we didn't have too much effort in terms of constitution of the committee, because that is also important, because there needs to be a good balance between public and private. So we also had workshops with the states, we had internal reviews, and then the final committee review, and it was approved by the governing board. So we had medical cell set up, so that was the initial stage when at the national level also we did not have a medical cell and an expert committee who were like, part and parcel of our organization. So we tried to ensure, and now we are pushing all the states to set up the expert committees at your level also, so that if there is any kind of discussion that needs to be done, we could connect with your experts and we could explain to them the rationale beyond this. And the second thing what we did was all the standard treatment guidelines, and also a lot of quality assurance mechanism, and we implemented a stronger medical audit and fraud control so that these packages that are being revised and rolled out, we can have better control mechanisms. So we tried a different processes, both from ensuring that we had a lot of evidence, whatever was available at that point in time. We had the Costing Health Services of India data, which was done by PGI and Chandigarh and DHR. So they gave us the preliminary results of those studies, so we could use it with our expert committees. And we also worked with, especially for oncology, which is a very strong, specialty, and uptake of those services are quite high. We had, with the National Cancer Grid, we had an MOU and we tried to work out these additional specialities and review. And for the processes, we also looked at that, more of rationalization of the terminologies, but not the rates. So we did not go all out and say that every time we did a revision, we were revising the rates for all specialities. So in this version, we did it only for 8 specialities. So in that sense, it gave us a little bit of edge on setting up the process and learning from that on how we can expand the same processes for all the specialities. So we looked at what are the prices, increase, decrease, retained. So we tried to introduce a lot of new concepts in terms of the stratification, and many of the redundant packages were removed. So we also reviewed it to that level. So the main few concepts we introduced was on stratifications, keeping the implant prices separate, cross specialities having the same code. Otherwise, it was reflecting as 1, 2, though the package was the same, because it was appearing in 2 specialities, it was counted as an additional procedure. So we rationalized that and made sure that 1 procedure, 1 code, so that it will help in analytics. And we made sure that there are add-on packages, so that, whenever the 100% reimbursement of such packages can be given. The standalone packages, which cannot be booked or clubbed with other packages, and packages with multiple procedures that can be booked. Static and dynamic procedures based on the implants or additional procedures that you add in. So we tried to bring in a lot of new concepts. And also follow-up packages was one of the concepts, because we understood that because the outcomes is also important. So patient having expensive surgeries but no follow-up will lead to bad outcomes. So we tried to at least identify some procedures to start with, and we are developing the follow-up, we have developed the follow-up packages for that. So 2.1 and 2.2 is more an incremental improvement. So mainly looking at what is that additional thing that was needed or missing. So there were minor adjustments made, but in 2.2 we made major adjustments only to the rates. So more than 400 packages rates were revised, but we looked at, the main thing was looking at the unspecified package. Remember the joker we added? The joker was creating problems because everybody was adding it for without much thought. So we tried to make sure that we rationalize the joker and make sure that we re-revise the guidelines for using that unspecified packages, and made sure that we listed some of the packages that were being booked as unspecified. So we worked again with a lot of committees, with DHR, with ICMR, with other stakeholders also, like FICCI, AHPI, CII. So we broadened, what I would say that, from HPP 2.0, wherein these stakeholders were consulted minimally, we tried to broaden these processes more and have more consultation with states, and looking at also identifying and rationalizing the minimum documentation set, so that the processing can also be improvised. So this was done internally within the NHA expert committee. So costing study, I think now we have the data from the private study, private hospitals also. So this was something that really helped us. I think more will be spoken in the specific session on costing, but definitely this helped us to give a perspective to those committee members to actually expand on how we can use the evidence better to rationalize the packages. So only one package was added in 2.2, which was mucormycosis, because COVID was going on and we did not have any package for that. But rest of the packages, we only did the rate revision, whereas in 2.1 we had some high-end packages which were being booked from the unspecified added. So HBP 2022 is the buzzword now. So we are now into the 2022 revision. But what we did beyond what we were doing all this while was more analytics, more cost evidence, and more stakeholder participation. So including patient groups, for the first time we included for some of the conditions, we had interactions with the patient groups, apart from much broader and a very systematic consultation, taking inputs from every state before we release the packages. So previously we used to have a draft package released and take inputs from the states, but this time what we asked them is to prepare the draft. We took inputs from the states, and as much as possible, wherever it was justified, we tried to incorporate it within the 2022. So we have all the specialities now, and making sure that we have now divided the unspecified packages up to 1 lakh as one package, 1 to 5 lakh. So we have tried to dilute the joker a little bit. So we have introduced the palliative care also, but we will be still taking more feedback on this specialty, because we want to, from the states, we want to take more feedback. And also for interventional radiology, though we have introduced, expanded the scope, but we have to make sure that we take further inputs from you, and we are introducing new procedures on the high-end drugs and consumables. So one of the other thing that we have also added is new high-end procedures like bone marrow transplant, cochlear implant surgeries, and making sure that there are some procedures which will ensure reduction of inpatient services. So some of the procedures, for example, preventive to diabetic retinopathy and glaucoma. So we have tried to ensure that those procedures, we have some screening so that which is in the facility, so that that can reduce the more serious complications of retinal detachment and more costly procedures being booked for those patients. Another key concept we have introduced is the differential pricing, because the stakeholder consultations led us to say that, you know, city-wise the cost of living is different, and the kind of reimbursement cannot be a flat rate across the country. So we have tried to use the 7th Pay Commission classification of cities as Tier 1, 2, 3, and ensured that we have a differential pricing or an adjustment that is made. And secondly, the adjustment is also made for a surgical and a medical package, so that secondary and a tertiary package, so that the tertiary packages are more complex procedures happening in tertiary facilities will get a kind of additional adjustments. Along with certain other quality accreditation we have already been doing for NABH, NQAS and aspirational districts. So these are an add-on to whatever the base price that we have set up. So this is just an example to say that, you know, the same procedure, there is a base price and there is a different price for each at the city level, and then but the implant cost will be the same across the cities. So we have not made the implant cost as differential. We have made sure only the procedure cost is currently differential. And new thing that we will have a session tomorrow afternoon is on the value-based incentives. So we will be dealing that in complete detail of what is the approach, what is the plan that we are looking at to roll out a value-based incentive approach to the pricing. So wrapping up, we have new concepts. We have tried to introduce it as a part of our work. One is to look at more better pricing negotiations. So we are looking at how we can have better strategic purchasing principles that could be used. So we are trying to come up with a document on the strategic principles, and then it could be the ministry or another independent agency who could use that. And this could be expanded beyond PMJY2 for other purchases also. And we have also have an innovative way of receiving the proposal now. We have a health financing and technology assessment unit within our division, so that we could, it's an all year round online portal where all stakeholders can request for the addition or inclusions that can go through a kind of a structured process of review. And in case it is a detailed assessment needed, we can have tie up with the DHR, who has the Health Technology Assessment Board in India, who can do some detailed studies on it. So the HEFTA unit acts like a secretariat and a screening committee, and we will work on that. So another thing we are trying to do is also the Payers Forum for Interaction and Standardization. ICD-11, ICHI, I think the WHO did share how we are working on. So it is being rolled out across the states, and we are still refining it, and it takes a little bit time to ensure that it is systematically implemented across the state. And the new thing, we will also have another separate session is on the DRG provider payment mechanism. So it is not only working on our side of how do we design the packages, but also how do we pay these packages. So we will be having a detailed session on the DRGs on what are our thoughts and how we feel that we have to move ahead in paying the providers.
Dr. Sudha, can we wrap up? We have
one more
talk
I'm already
after
done. So we will have these specifically. Just wanted to add on, the role of states is very important now, because we have given the flexibility to the states to add in these packages. So for us, you are very important to give your feedback, but also have your state specific committees to review the requests that you receive and make sure that you also have a systematic processes at the state level. So that is something that we expect from the states to do. And unspecified surgical package utilization review at the state level, because now you have the mandate to approve those packages up to 5 lakhs. So please have a very structured process in ensuring that you're making the right approval, because our role now is only auditing those approvals that the state has already given. So in case there are wrong approvals which are not as per the guidelines, then state has to bear the whole financial liabilities. So that is important. Please look at the US unspecified surgical utilization, and we have the guidelines uploaded in our website. Please go through that and make sure that that is something that you will work on. So, and we can still have any other questions and clarifications later, but this is overall to say that this is a joint journey. I would say that we are co-passengers in this journey. So we want to ensure that our interaction with you will be as frequent as you need it, and make sure that we'll work and make sure, and in the future as we move, we have taken a policy decision that we will review the packages every year. So that is something that we have committed for. So as we review every year, we will definitely make sure that your inputs are considered and taken seriously. So please keep those inputs and feedbacks coming as a regular process. So thank you very much, and open for questions.
Sure. Thank you very much, Dr. Sudha. So we can have the next presentation loaded. Until that time, if there's any question, any burning question, we can take one. Otherwise, we'll move on to the next in the interest of time. Yes. Yes, ma'am.
Hello all, I'm Dan Ollendorf, Director of Value Measurement and Global Health Initiatives at Tufts Medical Center.
Apologies, I didn't mean to press it, it just
Standalone thing, I would like to have a query, because I have raised this to some group, they have HBP group, but I have not received the answer on a standalone. There is a particular package, just for instance I am saying TBW, tension band wiring, there we have mentioned it is a standalone, but I don't know why there is a standalone thing in this practice, because there may be a patient who is having patella fracture, or there may be along with that other fracture, but it is a standalone. What happened in our state, the hospitals are raising unspecified because there is no other option to block TBW with other things. So standalone needs to be verified again why such thing is there. Standalone maybe you are keeping for to control abuse, but otherwise we are facing a lot of problems in processing. Then we have to see why they have blocked this thing. Already we have packaged. So this thing need to be reviewed again, maybe with HBP to 2022 or something.
We can discuss it later, but I think the point that you mentioned, that the primary purpose of the keeping the standalone packages is exactly to make sure that abuse prone packages are clearly indicated, and then there is no allowance for any kind of an add-on package along with that. So that's the main purpose for that, but we can discuss that later as well. So let's move on to the next one.
Thank you, Dr. Sudha and Dr. Shankar.
So I think this presentation that Dan is going to make is going to give the first initial peek into the methods that are to be applied in such decision making. So I think this is going to be an introduction, and then the next session will talk in more detail about the methods and its application. Over to you.
Thank you, Dr. Shankar. So briefly introducing Dr. Dan Ollendorf, whose recorded presentation we will be showing now. So he is a non-resident fellow at the Center for Global Development. He's also the director of Value Measurement and Global Health Initiatives at the Center for the Evaluation of Value and Risk in Health at Tufts University in the US. His research interests includes expanding the use of health technology assessment in low and middle income countries, as well as refinement of value assessment tools in the US. Previously, he was working as the Chief Scientific Officer for ICER, which is the Institute for Clinical and Economic Review. Dr. Ollendorf holds a PhD from the University of Amsterdam and a MPH from Boston University. He is currently the chair of the Health Technology Assessment International Global Policy Forum, and previously has served in the US Medicare Evidence Development and Coverage Advisory Committee. He has more than 100 articles in peer-reviewed journal and is also the co-author of the book Right Price, a value-based prescription for drug costs. So just starting the presentation now.
Hello all, I'm Dan Ollendorf, Director of Value Measurement and Global Health Initiatives at Tufts Medical Center in Boston, USA. Thank you for inviting me to speak about why an analytic approach to investing in health matters. I'm so sorry I could not be here with you in person for this important workshop, but I hope my thoughts will be of help to you. Before I begin, I'd like to disclose that I am under contract to the Center for Global Development on related work developing a rapid HTA process for NHA and ABPMJ. Some of the information I'll be presenting is sourced from a book that I recently co-authored on value-based pricing of pharmaceuticals, which I'm happy to say is available for purchase on Amazon India if you're interested. I have no other financial disclosures. My talk today is going to be broken into three major themes. First is an overview of how economic analysis can be used to prioritize and inform investments in health. Next, I'll talk about how formal health technology assessment uses these analyses to understand the value brought by health interventions. And finally, I'll discuss implementation of these concepts and processes in emerging health economies and how to embed what has been built in established settings in a localized approach. Before we get into those themes, however, let's look at this familiar graphic. Which of these steps involves analyses of value? Well, the answer is nearly all of them. Just to highlight a few, triaging and prioritizing services for inclusion in a health benefits package requires understanding of the value brought by each service, as we'll discuss. Conduct of any type of HTA, health technology assessment, requires an understanding of value alongside clinical benefit, risk, and other considerations. Using local costs makes a variety of value-based analyses more relevant to the Indian context. And understanding value is only beneficial while simultaneously understanding what the health system can afford. While all inputs into a final decision are important, I hope to show you today how no decision can be considered complete without an understanding of value. So what are we talking about when we discuss HTA relevant analyses? Well, there are several types, which I've listed here. Cost effectiveness analysis is the type that I'm going to speak about most today. And as you can see, it features in many of the steps that NHA and ABPMJ need to undertake to develop a value-based health benefits package. Extended CEA is another form of CEA in which some key non-health impacts, like the ability of an effective health intervention, like vaccination or nutritional supplementation, to provide household financial security. Budget impact analysis, which I just mentioned, provides a method to ground consideration of value in the reality of the funding available in the health system. And multi-criteria decision analysis is a way for decision makers to weight the importance of these various analyses and other factors in their recommendations. But back to cost-effectiveness analysis itself. Let's talk for a bit about the basics of this type of analysis and how it can be used to support decision-making. The goal of CEA is to inform how much health would be gained by investing in a drug, device, or program, and whether the additional money required is a worthwhile investment. The only way to make these comparisons fairly is by using a standard measure to summarize health. In many HTA settings, this is the Quality Adjusted Life Year, or QALY for short, which uses a straightforward method to adjust future years of life gained by a treatment for the quality of life experienced after receiving it. That quality of life is measured on a scale that ranges from 0 to 1, and is driven by estimates from general population or patient surveys of what life is like in a given state of health. Here's a simple example. Let's say a new drug provides an additional 15 years of life. The drug prevents progression of disease for 10 of those 15 years, so the patient's health is not diminished. For the remaining 5 years, there is some progression, but quality of life is still reasonably high. Some simple math yields the quality adjusted equivalent of this additional survival, 13.75 years. The math is simple, but not without controversy. Some people feel that low quality of life ratings mean that analysts are valuing patients with a severe disease somehow less than other people. But it's important to remember that the principal use of the QALY is to compare treatments, not patients. And if a treatment improves quality of life, it matters less what your starting point is. So now let's look at a full CEA calculation that includes cost. The output of a CEA that compares two alternatives is known as an incremental cost effectiveness ratio, or ICER. And again, it's relatively simple. It's simply the ratio of the difference in cost between the two treatments, the two alternatives, to the difference in QALYs. And the ICER is expressed as the cost per QALY gained. While the calculation is simple, it is often the output of technically complex models that extrapolate these outcomes over a very long period of time, often a lifetime. And how should we interpret the results? Well, these are often displayed on what is known as a cost effectiveness frontier, broken into 4 quadrants. Some of the decisions you might arrive at are quite clear. For example, if a new intervention's ICER ends up in the upper left quadrant, you would typically reject it because it's more expensive and less effective than the alternative. Alternatively, an ICER in the lower right quadrant would lead to universal adoption because the new intervention saves money and lives. But most new treatments end up in the upper right quadrant, where that decision must be made. Is the additional investment we must make worth it? And that is where HTA, or health technology assessment, comes in, as the recommendation-making approach that formally integrates these value concepts. HTA has also been around for a while, about 60 years in fact. In health and other industries, it was really a natural evolutionary need to keep pace with an increasing level of technological innovation, while keeping an eye on how to make the wisest investments. HTA exists in some form in every developed nation, but it has been slower to gain a foothold in lower income settings, where its benefits might actually be greatest given the health system constraints and level of resources available. So we've talked about using CEA to inform investment decisions, but how does this happen in practice? Well, the answer is through the use of cost effectiveness thresholds, which are intended to represent the point above which the opportunity cost of funding a new investment is greater than that of the current standard of care. Or to put it more simply, that the health gained by a new investment compared to the health displaced by taking funding away from existing services to pay for it is greater. Technologies with ICERs below any threshold should be considered for funding. Determination of what is good value is done very locally. For a long time, it was thought that per capita income, or GDP, was a good proxy for how much a given country was willing to pay for an extra unit of health. But as you can see here, the UK's long-established threshold of about 60,000 parity-adjusted US dollars per QALY is 1/3 of Belgium's, a country with a similar GDP. And the Czech Republic's GDP is about 25% lower than Belgium's, but its threshold is almost sixfold lower. So clearly something other than GDP and income is driving these numbers. How much can each health system afford, for example? Regardless of how a threshold is set, decision makers should be clear on the rationale for setting it and any exceptions that might be made for certain clinical conditions or vulnerable populations, for example. Cost-effectiveness thresholds are not the only element of HTA to vary. There's variation in how the governance of these organizations is structured, what their focus or remit is, how binding their recommendations are, and other elements. Taking Latin American examples, we see multiple structural approaches, including that of an independent autonomous organization in Colombia, and at the other end of the spectrum, a small unit entirely embedded in the Ministry of Health in Ecuador. I'm not sure if this has structural relevance, but it's worth noting that Colombia makes use of CEA in its analyses, and Ecuador does not. In terms of guidance, the HTA authority in Brazil was recently authorized to have its work inform exclusion or inclusion of technologies from coverage lists that all private insurers must abide by. While other settings like Argentina and Colombia do very advanced technical work, often with academic partners, however, their guidance is non-binding. Speaking of technical work, some of the challenges experienced in low and middle income settings have to do with limits on technical capacity. In the Middle East and North Africa, for example, there is only one formalized HTA agency at this point, and severe limitations on available training for HTA. Some relief is in sight with recent developments in postgraduate training that have become available in Egypt and Lebanon. So now let's turn our attention to assessing treatment value in low and middle income countries, both the potential and the challenges. Historically, the focus on value assessment in emerging settings has served two distinct purposes. These analyses have supported benefit package design or refinement by helping to prioritize services to fund, defining target populations for certain interventions, or developing treatment pathways that might have multiple interventions embedded within them. And as I alluded to earlier, CEA and other value assessment techniques can be used to inform whether to replace or augment the current standard of care with a new intervention, either wholesale or with conditions on its use. These analyses can also help decision makers to understand where in the pathway a new treatment should be optimally set and what price delivers the value that the system is looking for. So here's a recently published example that shows how cost effectiveness analysis and some of its related outputs can be used to rank services for health benefits in a given country. So Malawi is the example here. In this case, services are actually ranked by the health gain provided by each intervention on a population basis. And just a note that the measure used here is the disability adjusted life year, so DALYs averted, which is a construct that is similar to the QALY. I won't get into detail on it here. So once a ranking by health gain is complete, then attention can turn to the cumulative cost associated to the system. And so once that cumulative cost is calculated, it's possible to identify how many services will end up above the available funding line to understand which of these services can be funded. But importantly, they are prioritized in the first place by the health gain that they deliver to the population. Another example comes from Ethiopia. In this case, services are ranked in terms of cost effectiveness, where the lowest ratios at the top are the most favorable. This information can again be coupled with the available budget data to understand what can and cannot be funded during a given cycle. But again, importantly, the prioritization is done by understanding what is most cost-effective first and prioritizing that for funding. Okay, so that's benefit packages. But is individual technology value assessment really that important for low and middle income countries? Well, yes. One of the most prominent examples of adoption without consideration of value is the expert diagnostic tests for TB and HIV, which were taken up by low and middle income countries all over the world, even though the price of these tests far outstripped their value in many circumstances. As a result, Médecins Sans Frontières and other organizations issued loud public calls for reductions in the price. There are some other examples of so-called poor buys for the money in low and middle income countries. And these relate to situations in which universal use is considered as opposed to a focus on the population most likely to benefit. So you see the example around preventive cardiology in Tanzania, diabetes screening at an earlier age than is done in most situations, and universal pre-employment drug testing without any risk calculation in Bhutan. So as recently documented, the cost of overspending relative to the value of a given intervention or a set of interventions has an opportunity cost that's really not just in terms of money lost, but in lives lost. So health systems that overpay for high-priced technologies cannot fund broad population-based interventions, and population health suffers as a result. Here's an example that speaks to a very timely and relevant challenge based on an analysis done in Argentina. The exercise first involved treating an assumed 100 patients with spinal muscular atrophy, a rare inherited disease, with a new orphan drug, Spinraza, which would be estimated to save the lives of 30 of those 100 patients. This drug cost approximately 7.9 million rupees per year in Argentina. Using that same budget to buy additional respirators to treat hospitalized COVID-19 patients would have allowed Argentina to purchase over 2,400 additional respirators, which would have saved over 4,200 lives. So the opportunity cost in this particular example is the 4,170 lives lost by using that money for Spinraza instead. A final thought on some of these realities in low and middle income countries. As in any setting, coverage and price are closely tied together. All systems will struggle to make a technology available, even a good one, if the price is unaffordable for the system. Because of this, many low and middle income countries have decided to tie what they pay for new treatments to the price paid in other settings, which is known as international reference pricing. This may serve to lower the price in the short term, but it certainly introduces other challenges. For one, it will cause a convergence in price between countries, which ignores any individual country's ability to pay. So richer countries may save money under a reference pricing system, but that same price may be unaffordable for other countries without that level of resources. And the system is ripe for gaming. Companies might delay launches of drugs in lower priced countries that would bring a reference price index down, or exit those markets altogether. In addition, the list prices that are referenced may be artificial if the discounts received are confidential. But perhaps most importantly, using another country's prices also means you're importing how that country feels about value, as well as any technical details that went into the value calculation that may be very different from your own context. So for that reason, we tend to suggest that value-based pricing, value-based analysis be reflective of the local context and of the societal values that exist in a given country. So let's wrap up our session. applying HTA and CEA to investment decisions need not mean that you must build everything from scratch. For example, sources of data on intervention cost effectiveness are available even in settings without the capacity for full-blown de novo CEA. These include the Cost Effectiveness Analysis Registry, maintained by my center at Tufts University with nearly 11,000 published papers, the Disease Control Priorities Effort, which has published disease-specific guidance on intervention cost effectiveness, and the Health Interventions Prioritization Tool, which can combine public and local data to create a path to optimal investment. But here is what I want to leave you with today. All of what I said boils down to one critical concept, which is that purchasing that does not consider opportunity cost sacrifices lives and wastes money. It's as simple as that. I hope that I've shown you how HTA and CEA specifically can help with both benefit package prioritization and price negotiation. And these steps can be taken in India now, even without a completely formalized structure for HTA and CEA. So thanks once again for the opportunity to speak with you. You can reach me in these ways if you have any questions, and my best to all of you for the rest of the workshop. Thank you.
Thank you. Thank you very much. Is Dan going to be here for a live session? No.
No, he's
okay,
not joined us.
Fine. So I think he's tried to give us a initial kind of a bird's eye view into using some of the methods, and one of the methods that he has introduced in his talk is around the use of evidence on cost effectiveness to making three types of choices. Actually, he tried saying that in his talk as well. So the first application of this cost effectiveness evidence he indicated towards making decision on whether or not we incorporate any new treatment into our benefit package. So that was one. So, and he gave illustrations that the interventions that are proven to be cost effective should be the ones that should be given precedence over the others for inclusion into the benefit package. The second application he mentioned was around making choices for the standard treatment workflows or standard treatment protocols. So that's another application that he mentioned. And the third, he said, was around the pricing. So at what price would you like to keep a particular service or an intervention? Again, evidence from a cost effectiveness analysis can help guide. And one of the things that perhaps if you can take back as a message is that kind of a 2x2 table that chart that he tried showing, where he said that eventually two boxes are no-brainers. Okay, so if your new intervention costs more and saves less lives, then obviously you don't take that. If it saves money and saves lives both, then obviously you take that up. The real question comes in when you are in the top right and the bottom right quadrant, where in most instances you tend to be in the top right. So you have new drug or new device or new diagnostic test that is being offered, which has a better clinical effectiveness but comes at a higher price. And that's where your decision making or decision making about what you refer to as value comes into picture, and and that needs to be justified, that whether you consider that as cost effective or not to pay that extra amount for that additional health benefits. So I think that was just to summarize the key messages from his talk, but I'm at the risk of low blood sugar levels, I'll still offer an opportunity for people to come up with any questions or any clarifications that you want to have. Yes, please, sir.
Yes, sir.
Sir, it's not working, sir. Can we have somebody? Yeah.
Yeah. We are talking about the cost effectiveness, and again, the health is the right of the person. We have to consider that. If you consider the health is the right of the population, right of the person, then this is it's the responsibility to give the service, whether if it is most so effective in the treatment way, then why you should consider for cutting it as because it's not cost effective, because price is high. So that is my question. So we have to think about the life of the person, because the productivity will be lost. If a person lives longer, his productivity rises and the nation is gainer. We have to consider that part also, because it is almost theoretical, sir. We have to go practically. That's my point. Thank you.
Sure, sir. I think he's raised a point that should have come in this session, because if that point would not have come, we wouldn't have been able to reconcile on this particular issue. So the point is that why on one hand we want, while on one hand we want to aspire for universal health coverage and ensure that everybody has the right to all kinds of healthcare services, and on the other hand we are trying to say that we deny care to the ones just on the for certain interventions that may not turn out to be cost effective. I think let us rewind and see what we do in our usual health systems to answer the question. In the usual health systems, we are always faced with a situation where resources are finite. Our budgets are always finite, constrained. Even when we are told in early years of NHM, when came into being, and we were told that states were told to plan and plan PIPs, but there was always a resource envelope that was always communicated to them. You have to plan within these resources. Now, you know, and when you do that, you always have to make certain priority setting decisions. You have to make certain decisions to set your priorities. The point is that whether you do that explicitly or whether you do that implicitly. Now in our routine health system, how does it function? We have resources that are limited. In our public hospitals, the number of doctors are limited. These doctors can see their outpatient clinics up to a certain point of time. If you keep up the registration open beyond, let's say, 11 o'clock, the number of patients who starts to come in, you will need doctors to be placed beyond 5 o'clock or 6 o'clock in the evening to run the OPDs. And so as a result, in public hospitals, you stop your registration counters for outpatient clinics at 11 o'clock. Several of public hospitals, I would know, at my own institution back at PGI, you stop the registration for an OPD. Any patient who comes thereafter goes to the emergency. So we've stated that yes, you go to the emergency, but in a way we've said we stop the OPD at 11 o'clock. We are rationing on time. We are rationing care based on a time limit that we have set. We say that we want to provide primary health care to every individual. And then we start setting up norms for, population norms for setting up sub-centers or primary health centers. Now a primary health center we set at a population of 30,000, and then for 30,000 we define an area, which is, the PHC tends to be located in one particular village, but there is a catchment area of that village. Now here is a rationing by distance, geographical rationing. So the one who is living the distant far off from the PHC, we are rationing care to an extent based on certain distance. We have limited resources. We started a scheme for financial protection, but we only limit it to the ones who are the bottom 40%. We want to do universal coverage, but then we take some, we move towards a progressive universalism. We know that we want to aspire to have services provided to everybody. So we want to, but we set up a scheme which only covers 40%. There are people who run from 41st percentile till 60th or 70th percentile who are not too different from the ones who are in the bottom 40%. So here we are trying to ration care based on some test of income or some test of social vulnerability. The examples that I'm giving you are just to illustrate the point that we continue to do rationing in our routine healthcare delivery systems at every point of time. The whole thing that this method is trying to do is to make that job of priority setting or rationing a little bit more rational. So you put some criteria or some rules. On what basis would you make a choice whether or not you include a particular intervention for public provisioning, or where you use the tax money to pay for those services? So that's the whole thing that this is trying to do. And in order to do that, the long-term objective is, if you choose interventions that are more cost-effective, then eventually you maximize on the population health. You maximize on the number of people who get the services, you maximize on the number of people who can potentially be saved, and you maximize on the number of life years that you gain. So that's the whole purpose. But at the end of the day, definitely there will be, there is definitely a room to continue to advocate for more resources. More resources and to continue to add more services and to continue to add more people into the coverage, and that's when we are likely to reach to that goal of universal coverage.
Just to mention, we will be continuing this discussion on analytic methods after lunch, but I think it's 1:30. We'll break for lunch. May I request, if it's possible, to come back in 45 minutes? We are running half an hour late right now. So 2:15, can we aim to be back here? Okay, thank you very much. Inside that folder. The folder is here. Yes.
New hospitals, to increase the vaccination program, to give coverage to high-cost drugs, to provide nutritional supplements, to provide extra antibiotics, and to build new neonatal intensive care units. No? Suppose these are the options. So you receive this list, but you ask the HTA agency and to provide more information. Say, well, I need to know what is the effectiveness that I can expect in my city if I implement these interventions. And after a couple of months, because the HTA agency works very well and very quickly, they provide you with this information. And here the effect is measured in terms of points of infant mortality that can be decreased. Is okay? Is this clear? Okay. So my first question to you is, would you like to be able to implement all these interventions? Raise your hands if you want to implement all these interventions. Yes, why not? They are, all of them are effective, so I think that's, yes. And if we could implement them all, we could achieve a great reduction in infant mortality. So yes, I want them all. I am the Minister of Health, I want them all. The problem is that we, as health ministers, would like to have the resources to implement all these interventions, but we have a budget constraint. It is not our decision, the budget. No, this is a restriction over which we have no control. Usually, ministers cannot increase their own budget. At least in all the countries I know, ministers want more budget, they want, but they have no control over the budget. No, that's the control of the country, the president, the Congress. No. But as ministers, our obligation is to ensure that this budget will be used in the best possible way. This means that we have to use it in a way that is effective, that is efficient, and that is fair. And we need to prioritize. So the next question that you will ask to the HTA agency is the cost. How much money do you need to implement this in the city? And you receive this information. For example, improving the primary care network will cost 7 million rupees. Improving pregnancy control will cost 11 million rupees, and so on. I hope that you in the back are able to see, because okay. Maybe you are young and you can see better than me. So how to prioritize here, no? I will ask you another question. What is the more effective intervention that we can see here? Primary care, that's correct. So we will try first to see what happens if we choose the most effective one. So this means that we are going to prioritize based on effectiveness, no? This is the way medical doctors used to think, no? I just want the most effective intervention. I don't care about money. I don't want to think about money. I just want to implement the most effective interventions. Let's see what happens. So the most effective one is primary care. The second most effective? New hospitals, correct. The next one? Vaccine. Oops, sorry. Oh. This is really bad. Sorry. I need to start again. I ran to the end of the presentations. Sorry. Wrong button. So here we have the most, this is another. So let me now that I will reorder this list from the most effective to the least effective, okay? So now the first one is primary care, the second one is new hospital, the next one is vaccination program. But now you can see that if we choose based on effectiveness, we will be able to choose just two interventions, the two most effective ones, primary care and new hospitals. That's all, because that is 41 million rupees. You have just 40 million, but okay, 40 million, 41, probably happens everywhere. It's okay. So do you agree with this option? So we managed to reduce infant mortality by 36 points because primary care reduced it by 20 points, new hospitals by 16 points. So it's okay, not bad. But maybe that was not a very smart option, no? Because let's see what happens if we think in terms of cost effectiveness. And as Dan Ollendorf previously explained, you can estimate the incremental cost effectiveness dividing the cost and the effectiveness, no? And in this case, for example, if you want to know, this is a very simple example, no? If you want to know the cost effectiveness of implementing primary care, we need to reduce the cost, that is 7 million rupees, by the effect, that is reducing 20 points infant mortality. And that will give you an incremental cost effectiveness ratio of 350,000 rupees per point of mortality decrease. It's okay? So we can do the same, for example, with pregnancy control. No, we divide the 11 million rupees that cost implementing or improving pregnancy control by the 10 points that could be reduced, and that gives you a cost effectiveness of 1,100,000 per point of infant mortality decrease. So we can do the same with all the list, and now let's see what happens if we choose not the most effective ones, we choose the most cost-effective ones. And another question, what is the intervention that is most cost-effective here? Exactly, primary care. And the second most cost-effective one? Vaccination program, excellent. And the next one is antibiotics. No, this is just an example. So now allow me, I will reorder the list beginning with the most cost-effective and the less cost-effective. And then we can prioritize based on cost-effectiveness. We start with the most cost-effective ones, and we can choose all these interventions. We can choose primary care, vaccination programs, antibiotics, pregnancy control, nutritional supplement. Note that new hospitals now is not included because new hospitals was the second most effective, but it is not cost effective from this point of view. Now, we are able to reduce infant mortality by 60 points. And again, we are using 41 million rupees of our budget. So if we compare the two options, no, the first one, on your left, you were able to reduce just 36 points of infant mortality. And when you consider cost effectiveness, you were able to reduce 60 points with the same budget. So I think this is a very good example of the opportunity cost, because as Dan mentioned previously, opportunity cost is not about overspending, it's about life lost. And in the example on the left, it was a bad decision because there is life lost on those decisions. And there is also a very close relation between the threshold, the cost effectiveness threshold, and the budget, because here we start choosing the most cost effective, but when we reach the limit of our budget, that means that we reach our threshold. So we can see this in the graphic. No? This is our threshold, and all the interventions below the cost effectiveness plane are considered cost effective. Vaccines, primary care, nutrition, pregnancy, and over the threshold, new hospitals, intensive care, high cost drugs are not cost effective. But what happens if we increase the budget and instead of 40 million rupees, we have 75 million rupees? Well, in that case, we can include new hospitals, and that means that we will have a new budget, no, where new hospitals now are included, but intensive care and high cost drugs still are not cost effective. Now, this is just to show this relation between the threshold and the budget. So one question may be, what is the cost effectiveness threshold in India? I don't know if there is an official threshold in India, but there is a study from University of York that they found that the threshold in India is between 22,000 and 35,000 rupees per disability adjusted life year. This is around 0.2 GDP per Dali. Our group also have studied the threshold around the world, and we found that in India it's around 45,000 rupees, that is 1/4 of GDP. But as I mentioned, there is a close relation between the budget and the threshold. For example, health expenditure in India is 3.6 GDP. Is that correct? Is around that? Well, it's very low. Compared to other countries, it's really a very low proportion of the GDP devoted to health. So in case that India sets a goal for the next 5 years to reach a health expenditure that represents 5% of the GDP, and assuming that India will grow at a 6% of the GDP per year, this means that India would need to increase by 13% per year the healthcare budget to reach this target of the 5% of GDP. And that means that then the cost effectiveness threshold will be around 180,000 rupees per year, more around 1 GDP. But anyway, this is technical discussion. There is more research needed here, but probably there is, the threshold is between 0.2 and 1 GDP per capita per life year or per disability life years. And here we have another example of why it's important to consider the cost effectiveness of intervention. No? Suppose this is a health benefit package from India, for example, and that India has this cost effectiveness threshold of $2,000 per Dali or per Quali. This means that today in the health benefit package you have cost saving interventions and you have interventions that have a very low cost per QALY. On the opposite, down there, you have interventions that have a cost per DALY that is close to the threshold, no? Around $2,000 per DALY. There are other interventions that want to be inside the health benefit package, but you cannot allow them all to be part of the benefit package. No? So what this country does is, if there is a new intervention, they start doing an economic evaluation, and suppose that they find that this new intervention has a cost effectiveness of $500 per QALY, per DALY. So that is cost effective in this country. What do you think? If the threshold is $2,000 and the cost effectiveness is 500, yes, it's cost effective. So they can include this technology in the benefit package, because they know that in case they cannot increase the budget, the interventions that will be displaced offer lower value for money than the new intervention. So it is a good decision. But now suppose there is another technology, it's a new technology that wants to be inside the benefit package again, and you do an economic evaluation and you find that the cost effectiveness is $6,000 per QALY. This is cost effective in this country? No. So the decision should be not to include this, but why? Because if you decide to include this will displace other interventions that offer better value for money than another one. So it was a bad decision. It was effective, yes, it was effective, but it was not cost effective. So we have discussed up to now why it's important not to consider cost effectiveness. The problem is that it's not easy to generate economic evidence, no? Mainly in developing countries, it's not easy. So one option is to conduct a local economic evaluation, but that requires a lot of time, financial resources, a lot of data, so it's not always possible to do a full economic evaluation for every decision that you have to make. Another option is to do a formal process to transfer an economic evaluation from another setting to your country. But also transferability of economic evaluations is difficult, is also complex. You need country-specific data, country-specific cost data, so it is also a difficult option. So on the other extreme, you have these pragmatic approaches that we are going to discuss today, what is known like adaptive HTA, that maybe it's an option, it's not the best option. The best option is to perform a full economic evaluation. But when that is not possible, we are going to discuss these alternatives. And why this is important. Suppose that you have an old benefit package and you need to revise the benefit package. So probably in your package now, you have interventions that represent good value for money, and that should stay in the benefit package. But probably there are also another interventions that are outdated, and you need to exclude them from the benefit package. You don't know, but probably there are many. And probably there are other interventions that should never have been part of the health benefit package because there is no evidence on its effectiveness. They do not represent good value for money, and it's very important to disinvest in low value services. And on top of this, you have all the new interventions that appear in the last years, and you need to make a decision whether if you are going to include this in the benefit package or not. This is something that happens in many countries because they design a benefit package and after 5 years it is not updated, and you have this situation. So all these are interventions that need some kind of assessment to decide if they are going to remain in the benefit package, if they are going to be included in the benefit package or not. And I'm showing here some examples from Argentina and Uruguay that this can be as a large list of interventions, 100, 200 interventions that you need to assess in order to make a decision. And it's impossible to perform 100 economic evaluations in half a year, for example. No? So this is a very common situation in low and middle income countries. So we have this, it is not new, but it's a new term in some way. No? It's adaptive HTA. You have this paper from Cassandra Nemtsov, also Calypso, well, Abha, you're also part of the research group. And this is a very good summary of this adaptive HTA methodology, but it is not something new. Maybe you know this paper from Francis Ruiz and Calypso Chalkidou that was in updating the benefit package from Romania. This is just another example on how they use a very adaptive HTA methodology to have economic information, because they wanted to make decisions regarding the benefit package considering cost effectiveness, but they were not able to perform a full economic evaluation for each technology, so they apply this rapid methodology. No? This is another example that you may know in the world is Yacht from Thailand. It's also an example of how a country apply a rapid methodology to update the health benefit package. So I'm going to show really very simplistic example, no, of why it is possible to apply this methodology in certain circumstances. No? Suppose, imagine that there is a new drug in India, suppose a new drug for cancer, and the cost per patient of this new drug is $10,000. There is no economic evaluation about this drug in India, so the cost effectiveness in India is unknown. And India needs to make a decision on the inclusion of this new drug in the benefit package. Can we conclude anything about the probability that this new medicine will be cost effective in India? Well, the first answer is no, because you do not have an economic evaluation in India, so you do not know. But I will give you an additional information that is public. No? Let's say that in UK, this drug costs the same as in India. The cost is also $10,000 per patient. But the HTA agency in UK or in England, NICE, they performed 1 year ago an economic evaluation, and they found that the cost effectiveness in the UK was $40,000 per quality. And on the top, you have the comparison between India and England regarding the GDP. GDP in England is 20 times bigger than in India. And a comparison in the health expenditure per capita is 60 times higher in England than in India. No? And the HTA agency in the UK, they decided not to include this drug in the coverage because it was considered not cost effective. It's a very simple and extreme example. But what can you say now? What is the probability if at the same price it was not cost effective in England? How can this be cost effective? Pardon, it was not cost effective in England. What is the probability of how this can be cost effective in India? What do you think? You think there is a very low probability? Will you agree with that? I will say that it's quite impossible that this drug is cost effective in India, and I don't need to perform an economic evaluation to arrive to this conclusion. I hope that you agree with me, because we are talking about cancer here. Maybe if we talk about an endemic disease, something that has a very different pattern in India as compared to England, maybe there is something that we need to explore more. No? But in the case of most of diseases, if it is not cost effective in the UK at the same price, will not be cost effective in India. So this is more or less the basis of this adaptive HTA methodology. It's trying to get all the information that is available there and to have an estimation of the probability of that drug being cost effective in your context without performing a full economic evaluation that, I insist, that is the best information possible. No? Well, this is just a list of challenge in developing a health benefit package over time, and there are some questions that decision makers may have. No? For example, how do we know if a technology is cost effective in our context? What is a cost effectiveness threshold in our context? How might non-economic criteria influence our cost effectiveness threshold? So there are many questions, and this is just to show you a manual that we developed for the Inter-American Development Bank with Professor Mike Drummond and my colleagues at the Institute, that we try to answer some of these questions, and maybe there is an English version, and maybe you can find it useful also in your context. For example, one of the chapters is devoted to analyze how to use information from other settings to estimate the cost effectiveness in your setting, and analyzing different dimensions. No? And also we provide a way to translate incremental cost effectiveness ratio from other settings to your setting. No, this is just an example. But let's move to the next topic. That is, okay, I think that we all agree that cost effectiveness is important. From my point of view, it's impossible to prioritize without considering cost effectiveness, but I also believe that it's not correct to prioritize considering only cost effectiveness. There are other criteria and dimensions that need to be considered. And this scheme is just an example, is how the Netherlands makes decision about the inclusion in the benefit package of different technology. And you see that they start, the first question, I don't have a pointer, but the first question is this technology, this drug, is effective? If it is effective, the second question is cost effective? And if you see, if the answer is no, it's not cost effective, they still consider other arguments, because it may be the case that there is something that is not cost effective, but there are good reasons to include it anyway in the benefit package. But also note that in case that it is cost effective, if the answer is yes, it's cost effective, there may be reasons not to include something even if it is cost effective. We are going to discuss about this now. So we are going to talk about two dimensions, no? Budget impact and equity. So budget impact analysis. Thank you. Wonderful. So budget impact analysis, I think maybe you are familiar with this. This is like a new barrier, no? This is the barriers that new technologies need to overcome, no, before reaching the patient. They need to show that they are safe, the efficacy, the effectiveness, the efficiency, this is the cost effectiveness, but also the affordability. This is very important, no? We need to know that we can pay for this. So what is budget impact analysis? No, this analysis is something, and is something that is different to cost effectiveness analysis. No, it's something totally different. Budget impact analysis analyzes the financial consequences of the adoption and diffusion of an intervention. No, it's something that is very important for the budget holder. And this is some of the questions that can be answered by a budget impact analysis. No? What would be the impact on health insurance budget if we include this new oncological drug in our list? How much should the health budget increase to meet the population's demand for vaccines in the event of a coverage decision? what would be the expected cost or savings for a budget holder if it replaces an old technology with a new one. So this is the kind of questions that can be answered by budget impact, no? And it's being used in many Latin American countries, for example. Many countries require cost-effectiveness evidence, but they also require budget impact evidence before deciding on an intervention, no? So it's increasingly being required along with cost-effectiveness analysis, and it's also very useful for budget planning and forecasting, no? It's very important. Oh, this is an example from the UK, the budget impact test, no? In England. Cost effectiveness is very important, but also in case that the technology will imply a cost over £20 million, even if it is cost effective, this will imply that we'll go for another route and will start also price negotiation because they care about the budget impact, no? Well, and I show you some practical examples. For example, the HPV vaccine. I don't know, in India, HPV vaccine is covered? Is currently covered? No, not yet. Okay. Well, when it was released in the market many years ago, HPV vaccine, at least in Latin America, was much more expensive than now. But at that point, it was very effective and it was very cost effective. But many countries refused to cover because it has a very high budgetary impact. To give you an idea, at that time, covering this single vaccine was the same as all the vaccines that were being covered at that time in those countries. So even if it was cost effective, but most countries say no because of the budget impact. When the price was reduced, it was included in the coverage. And hepatitis C drugs is the same. In very high-income countries, it was considered that it was cost-effective, but it was the cost was so high, the budget impact was so high that many high-income countries decided to say no, or at least reduce the coverage just to some specific group of patients, no? Because they cannot afford it, even if it was cost-effective, no? So now we can move to the last topic, that is considering the equity dimension in making decisions, no? So here, this is like looking just at cost effectiveness, no? You have here more cost-effective interventions, less cost-effective interventions, and here you have a range of policies. No? And the only thing you can say here is that this one is more cost-effective than this one. No? But if you include other dimensions, you have more information. No? This, for example, can be the equity criteria. Now I'm going to return to this example again. No? So this is not the cost effectiveness plan, no? This is something different. Here we are considering cost effectiveness here. So here is more cost effective and here means less cost effective. But we have an additional dimension here. Suppose this is equity. So here we have a positive impact on equity and a negative impact on equity. So as Dr. Shankar mentioned previously, no, for the other case, no, there are two no-brainer decisions here. If an intervention is very cost-effective and improves equity, we have to say yes. And if an intervention is not cost-effective and it harms equity, we have to say no. But there are other quadrants where we need to make a trade-off between cost-effectiveness and equity. And I will show this with an example from Thailand. In Thailand, it was determined that dental implants, you know what is that you take out during the night and you put it in the light table. That's No, sorry, that is removable dentures, no? And dental implants are something that are fixed, no? That you don't remove them. And they found that dental implants were very cost effective compared to these removable dentures, no? However, a large proportion of the country population still lack access to the standard of care. So they still lack access to the most basic dentures. So even it was a cost effective, but they know that if they expand coverage to include dental implants, they will increase inequality, since it would mainly be used by urban populations that would end up accessing this service when a large proportion of the population would continue without access to the most basic care, no? That's removal of dentures. So this is an example of a win-lose, no? It was cost-effective, but it harms equity. So it is important to make a decision there. There is a trade-off. And this is a very nice book. It's Making Fair Choices on the Path to Universal Coverage. It's a very interesting book from WHO. And they provide some ideas, no, on how to make decisions, no? For example, to categorize services according to cost effectiveness and priority to the worse off and financial protection. And first, expand coverage for high priority service. And well, I will go to the example. And this book also provides very good examples of what they call an acceptable trade-off. And one unacceptable trade-off is to expand coverage for low or medium priority services before there is a near universal coverage for high priority service. So this is why Thailand decided not to include implants. They were cost effective, but they will harm equity, no? So it's a good example of doing this. And well, there are different methods to estimate or to take into account. There is an umbrella term that is equity informed or equity informative cost effectiveness analysis. That is a term to include different methodologies to take into account equity. And the two main methodologies are the extended cost effectiveness analysis that was developed by the DCP. And the main characteristic is that it examines the social distribution of cost and effects in different, according to socioeconomic, for example, sectors in the country. And another methodology is the distributional cost effectiveness analysis that was developed by University of York and examines the distribution of health benefits and opportunity cost. And I will show some examples. This is, for example, extended cost effectiveness analysis, where you can see how the health effects or the private expenditures or the financial risk protection is or is not different between the different quintiles in your population, no? And this is an example of an extended cost effectiveness analysis of rotavirus vaccine in Ethiopia. And you can see that there are, these are the income quintiles in the population, and these are the deaths averted. And you can see that there are higher health benefits in the poor side of the population, and there is also higher financial protection, no? So this is a good example of a technology that is more effective, more cost effective, and improves equity. And this is an example of distributional cost effectiveness analysis. This is a study that compared two strategies for bowel cancer screening, no? There was a target strategy that was focused more on social groups with low uptake, and the another one was a universal strategy, not the same for everybody. And you can see that the target strategy that was focused on those social groups that needed it more was more effective in those groups. And this is a good example of something that was cost effective, but this target strategy was less cost effective, but improves equity. No? So we are here in this quadrant. We lose cost effectiveness, we lose some efficiency, but we improve equity. So I am ending my 45 minutes. And I think this is a key message regarding this topic, no, for decision makers, that some decisions involve or will involve trade-off between improving health and reducing health inequity. And such trade-off can occur, for example, when delivering services to disadvantaged communities that will require additional cost. I think in a country like India with rural population, this is probably a reality. And in such cases, equity, informative, cost-effectiveness analysis can help make decisions that are fair for the whole population. And I think I end here. Thank you very much.
I'll now request Dr. 𝒂𝒂𝒂𝒂 to please come and bring along with him the chair and co-chair of this session, Dr. Kameshwar Rao and Ms. Ruchira Agarwal. Requesting Dr. Dhananjay to please introduce them.
Thank you, Oba, for inviting. For today's session on analytical methods, we have invited our Executive Director from NHA of Monitoring and Evaluation, Dr. P. Kameshwar Rao sir. Dr. Kameshwar Rao has a vast experience of around 35 years. He has been graduated from Usmania University of Hyderabad, and then he has worked in an homeopathic central research council for almost 10 years, and then he was part of the oldest and one of the biggest schemes in India, central government health scheme, CGHS, for around 23 years, and he is our executive director of the monitoring and evaluation team from almost 1.5 years with NHA. We welcome you, sir, for today's session. And we also, along with him, we have Dr. Ruchira Agarwal madam with us. Madam has done post-graduation in management and sustainable development from Lucknow University, and she also has done post-graduation in the performance management from the University of Bhopal, and she has a very good experience in project handling and monetary evaluation. Madam has led a very big initiative of Madhya Pradesh, creating a new department on happiness, and she is now handling both capacity building and monitoring evaluation at NHA. We welcome you also, ma'am, for today's session, and I would like to hand it over to Dr. Shankar to continue.
I think I saw it. So, thank you very much. Thank you to the chairs I think some of my job of this particular session has been made a little bit more easier by the previous speaker, Dr. Andres. What I'm going to focus as part of this session, which is, I do recognize a post-lunch session, so I'll try not to make you sleep, but I'll try to make it a little bit more illustrative. So we've been hearing that since morning that we need a little bit of analytical methods. We've talked about a few analytical approaches, methods that have been outlined by Dr. Andres in his talk earlier. What I'll try to show to you is some of the some examples of the analytical methods that we've been using and making use of in decisions around health benefit packages. So by no means is it a kind of a didactic lecture to make you learn about new methods, but it is just to give you illustrations of how some of these methods that you've been hearing since morning, they've been put to use. And also referring back to the kind of circle that was shown earlier, the cycle of health benefit package revision, which talks about the looking at your existing data and then looking at new topics that have been received and doing some kind of assessments on that. So what could be the methods that you could use in order to fill that circle out? And I'll broadly talk about the methods in two domains. One, the type of methods that we've tried to apply in making decisions about whether you include a particular intervention or you exclude a particular intervention from your health benefit package. So that is number 1 and 2. And the second is the range of methods that we've so far applied in making decisions around pricing and changes around pricing, because there's again a discussion point that we have been having since morning, that how do we make decisions around pricing. And some of the I was also having discussion over lunch that people were asking that new interventions are being requested, but how do we decide on what should be the price? So those are the two broad applications, one on package inclusion exclusion and one on pricing. And within these two broad application areas, I'll try and show some methods that have been applied over the past. Categorizing, one of the analytical approaches that we use to make these decisions is making use of the existing data. And the existing data in terms of looking at the utilization data of the existing services. Second is the state-specific packages that exist. And third is the unspecified packages. So those are the three main types of data sets that we try and look at, and we try and make some analysis of the utilization patterns in each of these three broad domains. So the first is looking at the utilization. So whatever packages that we have, procedures that we have, we try and make some kind of analysis to see which packages are getting used more, which packages are not getting used at all for that matter. So for example, in the last revision, we realized that there are certain packages that do not have any utilization at all. So maybe just one utilization during the entire year. And the possible reasons could be that there are certain, either the conditions or the nomenclature of the packages are not appropriate, so those packages are obsolete as of today's medical advances, or the reasons could be that there are other alternate procedures that are already available that are more preferred by clinicians. So in such cases, we sometimes take a call on deleting some of these procedures. There are other packages where we find that there is a lot of booking of these procedures or packages in the unspecified category. So as was being mentioned in the talk by Dr. Sudha in the morning, that we have this joker, unspecified surgical package. So where you're not able to provide service to a particular patient, and if your medical board agrees and approves of the utilization, then you book it as an unspecified surgical. But even the unspecified surgical eventually has to give a reason as to what is the procedure being performed and for what condition is it being done. So we try again making use of this data and analyzing this data in order to see that which are the disease conditions or which are the procedures that are getting booked very often in the unspecified category. And the reason why we want to analyze this is because we want to see that if there are certain procedures that are getting booked very often in unspecified, then we should rather include them in the health benefit package. The reason is because when they're getting booked as unspecified, each state may resort to their own mechanisms of quality assurance, fraud and abuse control mechanisms, and also for pricing. Whereas if an unspecified package that gets to be used very often is made part of the national master and becomes uniformly applied,
Then there are uniform guidelines to utilization, uniform standard treatment workflows that need to be followed, uniform set of requirement for documentation, uploading, which makes the claim processing process also a little bit more systematic, and then also makes the assessment of any kind of abuse, fraud, etc. more easier. So for all these reasons, we try and do that. And again, there are some illustrations that are shown on the right of the slide, which shows that, for example, addition of ERCP, there, which was being used as unspecified booked as unspecified in several states. And then looking at the low uptake of peritoneal dialysis and finding that in some states, there was the catheter insertion was being used as an unspecified package. And that's where we realized that one of the things that we miss in our package master, especially for the uptake of peritoneal dialysis services, is actually a catheter insertion, which wasn't there in the past. So we picked this up during our analysis of the unspecified utilization. And we also generally, in all the consultations that we have with the specialist expert groups, we tend to present this data to them as well, looking at giving them a sense of what's the current utilization, what's the utilization of these unspecified, and also have their clinical inputs to see that whether these procedures that are getting booked in unspecified, are these really worth inclusion in the health benefit package also or not. Similarly, the third category of data that we try and analyze to look at the utilization trends is the state-specific packages. Because here again, we understand that there are certain states that add on more packages through their state-specific inclusions. And some of these packages do merit certain criteria based on which they should be included in the national master. So either these are conditions that do address diseases that have high burden, or diseases that impose high financial catastrophic consequences on the households who have to get treated. So as a result, we do make certain inclusions based on the analysis of the data that we evaluate from the state-specific packages. And two particular examples that I would definitely like to share, which got included in the new health benefit package in 2022, which were based on the state-specific inclusion rationale, were the bone marrow transplant, where we've now included the allogenic bone marrow transplant and the cochlear implant surgery. So these were again procedures that were getting booked in state-specific packages. So this is the 4 slides that I tried showing were basically illustrations of how the utilization data gives you some insights into what to include and what to delete. The second set of analytical methods that I'm going to move towards is something that Andres has already spoken about. I'll try not to spend much time on the initial theoretical aspect, which I included, which is already explained quite well. So he gave you a very nice numerical example actually. I've tried to convert that into a graphical illustration. Hopefully the message is the same. So the message is, let's assume that you are planners and you want to incorporate interventions into your health benefit package. Let's say you identify a certain set of interventions, and again you rank them in terms of their cost effectiveness. So on the y-axis, you find the degree of health that you are gaining with the investments that you are making. So the bars that are taller means that these are more cost effective interventions. You have the higher health benefits per rupee spent, and you continue to move and you continue to spend on till you reach a point where your budget has exhausted. So you spent on these interventions and your budget has exhausted. Now, it's a medical field is such an evolving field. Every day you have a new molecule coming up, new drug that is coming up, and a new interest group who's putting in pressure to include a new drug into the package. And so you have 4 new candidates that have been that you have received applications for inclusion into the benefit package. 2 clearly are more cost effective than the ones that are already there. 2 that are worse off than the existing ones, because the worse off are the ones that are less cost effective than even the least one that was already there in your package. So obviously you just simply discard them. Again, it's a very no-brainer, but you need to incorporate these, the ones that are more cost effective. Now let's assume that your budget is the same. You still have that 1,052 rupees per capita allocation, or you don't get an increase in the rate. So if you incorporate something, let's assume you can only do that as if you take out some intervention out of the package. Similarly, you do it for the next one. Again, you have to take out certain intervention. There is a very hypothetical example where you have the same budget resources, you have to add more interventions, and if you add more interventions, you have to perhaps think about removing some of these interventions as well. Now, when you do that now, you see that the extent of, so the area that gets covered under this shaded bars, that gives you a sense of how much health you have been able to improve for the population with the set of interventions that you rolled out. So this current set of bars shows you what you have been able to do, and the lower set of bars shows you the package that you had prior to the application of your health technology assessment. So in a way, the area that is shaded as yellow is the one that that represents the gain in health with the same amount of resources that you have been able to now make use of, but with application of some evidence-based principles of choosing interventions based on some criteria of cost effectiveness. So this is just to illustrate the same point, I think, which has been made since morning. Andres did try and make it in his empirical example also, where he showed you the costs and the outcomes and ranked order them. This is again showing that in the same graphical way. Now we do recognize that this is quite a time consuming and effort involving, and even this requires resources to even generate this kind of an evidence. So is it really worth even spending so much of amount of resources to even generate this evidence and make use of this evidence to decisions for policy, etc.? This is just an example from the UK setting, where they've set up this kind of a system of evidence-informed policy making for health benefit packages, decision making, etc. And this table basically shows you, the lower row shows you the overall cost of implementing such a program for HTA over the 20 years time period. It was about nearly 360 million pounds. Whereas the net benefit that you were able to achieve through application of evidence from just 10 studies that were published as a result of this entire effort over the 20 years, we're not taking all studies, we're just looking at 10 studies, that the net savings that the system was able to accrue was 10 times the actual cost of running the program over 20 years time horizon. So which means clearly it is, from a financial perspective also, and I wish we had our financial advisor also here listening to this, this is something which is clearly you gain even from a financial perspective, right? So you have a set of interventions that you have some evidence based on which you are able to make some decisions around pricing, make the prices more appropriate, etc., and that helps you to gain. And similar evidence comes from other countries as well. So even if you look at another country example, which is closer home in Thailand, there again, they were able to, they have several success stories. I'm just taking one out of them, which was use of one particular drug that was used, and within a 5-year implementation period, they were able to gain several $1 million worth of savings by application of this kind of policy making, decision making framework. And the reason why they were able to gain this much amount was because their entire price negotiation takes place following the evidence or the guidance from this kind of evidence. Now, how does this translate into our setting? Okay, so this so far theoretical. Let's come to our own setting. And I'll take you to one of the packages that we currently have, which is trastuzumab. A lot of you who are involved in decisions around health benefit packages and you keep sending us requests, and we also keep getting such similar requests from other settings also. Now, this is a very common, often used package for treatment of breast cancer women. And one of the key questions that is significantly debated is, how many cycles do you provide for as part of trastuzumab in the scheme? And it can range from 4 cycles, could go up to 8 cycles, but most of the requests come for either 14 or 18 cycles That's the variation that it is. And it definitely is a costly drug, so if left to patients, then there is a lack of access. So there is definitely a question about both access and financial risk protection. You look at the guidelines, there are varying guidelines between ICMR, NCG and PMJY. So there are different recommendations that come out of that, but the guidelines still to an extent remain and make it acceptable alternative, or sometimes in some cases for example ICMR, it says standard of care is 1 year because they have referred to the international guidelines. So what we then resorted to, we initially had 4 cycles that were permitted in the PMJY. We looked at an evidence on cost effectiveness, which was India specific, a study that was undertaken in India, and what it showed was that if you take the 9-week or the short course chemotherapy, trastuzumab, it has a 100% probability of being cost effective. If you take the one that is for about 8 cycles, which is a 6-month course, it still has a very high probability to be cost effective. But if you take the one that is long duration, which is 14 or 18 cycle, it is not cost effective. So based on this, we actually made this shift in the HBP and the standard treatment guideline also, that the number of cycles that would be allowed for payment would be not 4 but 8, but definitely not 14 or 18. So this is one area where we can clearly show that how the HTA evidence or evidence on cost effectiveness was used to make decision on health benefit package. And in this particular case, you can also say that even this could be used to guide even the standard treatment guidelines that are being drafted, and clinicians should make use of such evidence. There's another application, not yet, but we recently received this report from the Department of Health Research, where a range of different drugs, anti-cancer drugs, were evaluated for cost effectiveness in Indian context, and it showed basically that you can see a range of different drugs, and you also must be getting a lot of these drugs as requests for inclusion in the health benefit package. Majority of the drugs at the current prices are not cost effective, but this report also gives us an information that if the price is reduced, so the last column shows the reduction in price over the current market price, how much price should be reduced for this particular drug to be cost effective if it was to be used in the included in the health benefit package. So this again is a piece of evidence that is available that can be helpful to make decisions not just about inclusion and exclusion based on this column, but also on the pricing that you could perhaps consider if this was to be included into the health benefit package. So this is one illustration that I wanted to show when we talk about inclusion of health benefit packages using evidence from HTA. Moving forward, the second part of my talk is around the methods for pricing decisions. And here I'll talk about 3 main issues. That one is the need for cost data, and what cost data do we have, and what kind of use do we make of that cost data in order to set the prices. And second is a range of other sort of price comparisons, benchmarking, reference pricing, etc. that we try and do. Now, as we had been hearing since the morning itself, that when we had the first set of HBP, which was 1.0, it was basically an exercise that was done to quickly come up with a health benefit package, and the prices were determined based on a review of what knowledge existed. That means we looked around the prices, what was prevailing in RSBY or the scheme in Andhra Pradesh or in Tamil Nadu or similar other schemes. And we had a lot of consultative exercise, and that was done. At that time, what we missed was some kind of an evidence base on the cost. And as a result, since then, there was, at that time itself, a study was commissioned which was funded by the Department of Health Research, Government of India, which was to generate estimates of cost for the health benefit packages under the PMJY. And this study was undertaken by 14 institutions across different country, covering about 11 states in the initial phase, and then adding 3 more states in the last phase of the study. And this study has now been widely used for a lot of price revisions that have taken place subsequently. And this study has also been very widely published, which means that it has sort of stood the peer review of international journals. Methods have been well documented, published, disseminated. And as I was mentioning, that this study was undertaken in a large geography, because we do recognize cost data is very heterogeneous. So if I say that the cost of a particular procedure in, let's say, Chandigarh is X rupees, it may not necessarily be the same in, let's say, Chhattisgarh or in MP or in Tamil Nadu. And we know that it's very heterogeneous. So as a result, there was a concerted choice to have a very wide geography to cover this. And there were hospitals that represented both the public sector and the private sector, and within the public sector also the ones that were tertiary care and secondary care as well. And we know that private sector is very heterogeneous. So again, for sampling or picking up the hospitals to be selected for this costing study, there was a sampling that was done from hospitals that had different bed strength, that were located in different type of cities, and also that were different in terms of ownership. That means whether these were for-profit or not for-profit hospitals. So what I'm trying to just illustrate is the kind of heterogeneity in the sample selection that was there. And it was quite a comprehensive exercise to assess all types of services that are delivered in a given hospital, to ultimately assess the cost, whether it is the outpatient, inpatient, or it is the ancillary services like diagnostics or pharmacy, or it is the support services like the laundry, dietetics, or other services. And in at each of these points, all types of resources, whether these are capital or recurrent, they were all measured and they were all costed. And these were all estimates of cost that were generated, not the price, which means these are not the prices that were evaluated, which these hospitals are charging to the patients, but these are the actual cost of delivering care in these hospitals, given the amount of resources that are being spent, and given the prices at which they are procuring, these hospitals are procuring these particular drugs, consumables, etc. And based on that, we tried determining the package rate for each of these different packages that are part of the PMJY health benefit package, which included separately the cost for consultation, the diagnostics, the procedures, the stay in the general ward or the ICU or the post-op medication as well. So in a way, if I try and compare it against which all services are to be paid for as part of the PMJY package, and which all services were costed in this particular study, you can see that fairly all the check boxes are ticked on the costing side as well. So it tried to match whatever is the package construct of a PMJY package. And then what we tried doing, even if I'm not sure if it's visible from the last slide, but I'll try to illustrate what is written here. What you can see is that we tried comparing for each package what is the actual cost that is incurred, what is the price, what is the percentage difference in the cost and the price, and then what is the distribution of this cost in terms of outpatient, inpatient, ICU, OT, and diagnostic. And this is just an illustrative for just a few packages, but this was something that was done across a range of all types of packages that were available, for which the costing data was available. And this slide basically tries to show that we compared, when we used this cost data for the revisions that took place in HBP 2.0, we tried seeing that to what an extent was a correction of the cost price differential done between HBP 1.0 and 2.0. And what I want to highlight in this particular slide, is perhaps if you can look at the last set of 2 bars. What it shows is that in 2018, for 42% of the packages, the prices were 50% or less than the actual cost. So actually the prices in 1.0 were significantly underpriced than the actual cost of delivering those services in these hospitals. And based on the revision of prices that took place in 2.0, the proportion of such significantly underpriced packages was reduced to half. So from 42% it was brought down to 20%. And since then the constant effort has been to align the prices as much as possible to the available cost data that we have. And we've also tried not just looking at the cost data that we have, but also trying to reference that or benchmark our prices against some of the other schemes that exist. And we know that while we do these benchmarkings, it may not necessarily be a right way, because we don't know essentially how those other schemes have derived these prices. So while I show you a comparison between our prices and the CGHS, it is not to say that the CGHS is the gold standard and that's why whether we should make any changes or not, but it's just to say that because some providers do agree to CGHS prices, and then we should be also cognizant of the fact that we have a certain type of price comparison. So what it shows is that of the total 498 packages where there was a direct one-to-one match between a CGHS and a PMJY package, and where it was possible to compare prices also, because otherwise the the way in which you pay providers in CGHS and PMJY is slightly different. So it is not a head-to-head comparison in all cases. We could see that while in several of the packages, the PMJY rates are higher than the CGHS, in about 100 cases, they are lower than the CGHS prices as well. And this is again a very useful piece of work that was guided by Dr. Pramesh, who's here right now with us from the Tata Memorial Hospital. And based on, so they were advising us on how do we rationalize the packages for surgical oncology and the pricing for the surgical oncology. And one of the very novel ways of doing that we came up with was a kind of grading of each of these surgical procedures through a consultative exercise with the surgical oncologists to grade the extent of skill that is required in terms of performing a given surgery, the duration over which a surgery takes place, and the length of days over which you need to keep the patient post-op in the hospital. Each of these things in a way is a reflection of the amount of resources that are consumed for delivering a particular package or procedure. So the reason, and then you see that each of these procedures are ranked order in terms of, so a procedure that shows a grade 5 is something that requires more skill, more technical competence, versus another procedure that is ranked 3, which does not require as much skill as the other one, which is listed above. So in a way, the prices should also be able to differentiate these levels of skill mix that is required to perform a given procedure, the amount of length of stay that is required, etc., and all that. And then you see that the amount of cost for consumables and the medicines, etc., they were all estimated based on what exactly is required in each of these packages. So it's just an illustrative for you to understand that the kind of analytical approaches and the effort and the consultations that go into formulating some of the evidence base that is used for pricing decisions. And why is it that we ultimately want to do that? Because eventually we want to reduce the extent of cost price differential. So we heard Dr. Vinod Paul speak in the morning, trying to suggest to us that we need to make sure that our prices are such that neither they incentivize too much for any kind of a fraud and abuse, but at the same time they compensate for the level of resources that are consumed for delivering a particular care. It is also important alongside that, while you do all these analysis, to ensure that you do not, okay, 5 minutes. So you do not necessarily overspend and you're well within your budget as well. So again, this was an exercise that we did at the time when the HBP 2.0 was being done, where we tried looking at the budget impact. So this is, the blue bar represents the amount of money that would have to be the claim payout if you use the prices of 1.0 versus if you use it for 2.0, then what would be the claim payout. And it's shown that if you only change the prices of the top 100 packages, or if you go on to change top 200 packages, top 300, 400, 500 likewise, then what's the expected budget impact? And what we showed at that time was that the extent of budget impact, because there were some packages for which prices were increased, there were others for which the prices were decreased also in 2.0. So the net impact was not too much. This is what we tried showing at that time. And as a result, this sort of gives a little bit more confidence that eventually this is not likely to have much financial implications. The other part where we've made extensive use of analytical methods for pricing decisions is around the differential pricing that has now been introduced. I'll not go into more details, but I'll try and just show you some illustrations. So we do recognize that a single uniform price may not necessarily satisfy all providers and all geographies, because the prices vary across whether you are located in whether you have a hospital located in Delhi or in Bilaspur or in Raipur or in some other city. So there is a significant heterogeneity just by the fact that where the hospital is located. And similarly, there is also variation in prices whether it's a tertiary level facility or a secondary level facility as well. So these are some of the supply side or hospital characteristic factors that might influence the prices. And then there are some patient level characteristics which may also influence the price. So right now in the differential pricing, what we're trying to address is just the first part, which is the hospital characteristics, not the second part. The second part is something that we're trying to address as part of the DRG pilot, and we'll talk about that sometimes tomorrow. But what we tried addressing in the differential pricing analysis is the supply side characteristics. And we used standard methods of analytical approaches that are used in order to determine the price weights that help us to differentiate that how much more or less should you be paying to a hospital for a given procedure if he's located in a tier 1 or a tier 2 or a tier 3 city. And similarly, whether it is a tertiary care procedure or a secondary care procedure. So we had a range of different factors that we considered that could influence the prices for surgical packages. And then we had these sort of analysis that were undertaken. And finally, we came up with these kinds of adjustment factors to arrive at prices that are to be representative of the same procedure, whether you are in a tier 1 or a tier 2 or a tier 3 city. And this was done separately for a surgical package and separately for a medical package. Now, this is the last, I think, part of the 2 or 3 slides that are left, which is, despite having done all of this, you still have other considerations to also factor in. Considerations of fraud and abuse, considerations of the fact that you need to also manage access. So on one hand, you want to ensure that you gatekeep certain packages or procedures in the public hospitals, but at the same time, as Dr. Paul was mentioning in the morning about the neonatal care, perhaps in certain geographies, you might need to consider opening it up if the existing public facilities are not able to meet those packages. So these are some illustrations of the fact that there are examples where decisions on health benefit packages are made based on simply consideration of certain packages that may be either prone to abuse, they may be prone to upcoding, or we need to consider perhaps simply issues of access to care, and so in some cases make the prices slightly more attractive because there is not enough demand for those services otherwise. So those are some of the additional factors that may also play a role when you make decisions around choices for health benefit packages. The last slide that I have is just a announcement or a sort of placeholder that I wanted to show, that this entire data on the cost of healthcare services, we are trying to make it available for public access on a dashboard. And this is a health system cost database that has been developed through a joint initiative between the PGI, Department of Health Research, with this close technical support from the IDSI and the CGD. So this is one place where you would be able to have data available from the CHSI study in terms of the cost information, the data collection tools. A lot of price data is also going to be plugged in here. There is a unit cost estimator that is also available, which means that if you want to say that you believe that these estimates of cost do not necessarily represent your geography, you have an option to perhaps select a certain menu and fit in certain data like the hospital bed size, the average salary to a doctor in your area, the average volume of patients that get admitted in a given month, and this would auto-calculate and give you an estimate of what is the likely per bed day cost of admission in such a hospital setting. So I'll stop here and would be happy to answer any questions subsequent. Thank you.
Thank you, Dr. Shankar. I'll now invite Dr. Kameshwar Rao and Dr. Ruchira Agarwal for your reflections and comments from the session.
Good afternoon, everyone. Thank you for the opportunity of chairing this session. I thank the organizers. So we are extremely apologetic also that we could not come in time due to prior commitments at our office. Thank you for the very insightful and wonderful presentation from both the speakers, Dr. Andres, Dr. Shankar. Clearly, as I see for any country trying to achieve universal health cover, defining and redefining the health benefits packages remains a very daunting and challenging task. So towards this, I personally believe the analytics based approach tries to provide a very flexible and transparent mechanism to arrive at the decisions, especially so in developing economies. I read with interest Dr. Andres' work and his concerns. In fact, his passion towards the health equities, and everything has come out very nicely in his presentation. He's concerned that the high-cost technologies with limited benefit and some of the low-cost technologies, which can be utilized by most common people. So that striking a balance becomes very important, and that has been his passion, and he has clearly shown in his presentation. And Dr. Shankar, a very renowned health economist in India. In fact, both of them are very renowned health economists in their respective countries. So thank you, Dr. Shankar, for the comparison of different health benefits package and the analytics-based approach adopted in PMJAY. You have shown the different determinants of cost, the provider's specific features. There are some patient characteristics that are available. So in addition to this, what I would just like to add is that can we do some kind of research applying AI and ML technologies in this area? So AI and ML is the buzzword in healthcare. So as for human beings, we can perceive only at the most 3 dimensions. But we can definitely use AI and ML technologies which can capture the provider side characteristics or the patient side characteristics and combine them, and then can give better insights as to which of these features are more useful in arriving at a specific package at a reasonable cost. So that's one thought that I had. And with that, I request Ruchira Agarwal to take it forward.
Thank you everyone. Thank you organizers for having us here, and very interesting and insightful presentations from Dr. Andres, Dr. Shankar. Thank you so much. I'm not a medical doctor by profession, But I think 3 years in the National Health Authority, I've learned a lot about the medical profession also, and about the health insurance scheme and the PMJY and how we are functioning there. So hearing the two presentations, and when we talk about universal health coverage, the very PMJY is, I think, the forerunner or the basic stepping stone for a country like India in its progression towards universal health coverage, and providing health services through well-defined health benefit packages is one of the most important aspects of this scheme. And the presentations, as was highlighted by both the speakers, the evidence-based decision-making through cost-effectiveness data for inclusion of various packages is very important. And I think a lot of work is needed in a country like India to get this evidence, cost-effectiveness evidence collected for various alternatives which are available for inclusion in the health benefit packages. Also, as highlighted by you, the budget constraints are very, very important, especially in developing countries like India, to keep in mind when we are moving towards universalization. So that will also be a major factor when we are talking about inclusions and inclusions as far as the health benefit packages are concerned. And a very important aspect highlighted by Dr. Prinja was on the pricing of packages and the need for having some reference data and base data of costing in order to guide the pricing of the health benefit packages. And we hope we can have a few more studies, more vast studies and economic studies on this data also. And also keeping in mind, there will always be a lot of political and bureaucratic constraints when we are defining these packages. But as far as PMJY is concerned, I can surely say that we have been trying, we are trying to use as far as possible all kinds of analytical methods to ensure that there is a proper exclusion and inclusion of the relevant packages for the beneficiary base of PMJY. And we hope that we can strike that delicate balance between cost effectiveness and budget. Thank you so much.
Thank you very much. I'll open up for maybe 1 or 2 questions from the audience. I know we're running late, and after that we can go in for the tea break. May I request for a mic at the back of the room? There are 2 hands which are raised.
Thank you very much for your very informative presentation, and I want some clarity, and my point is this. In India, we are, particularly in Assam prospect I am telling you, we are facing a very great challenge in case of maternal mortality and infant mortality rate. In that case, the PMJY is playing a crucial role for improvement of the strengthening of the public hospitals in the form of reimbursement of the delivery packages, then the neonatal packages. In this context, in the HBP 2022, when I have seen it, it is seen that the cesarean delivery has been reserved for public hospitals only. Now, point is this, there are lots of districts where the public hospital facilities are not there. And people has to go, particularly in the Gwalpara district, then the Hosai, there are few districts in Assam, in Barak Valley also. So they have to go to private hospitals. And I have seen that the package like high-risk delivery is there for private hospitals. If the high-risk delivery is there, it's the diagnosis of the patient, but mode of delivery may be vaginal or maybe cesarean. It may end up in cesarean delivery. Then what is the point of removing this cesarean delivery from the private hospitals? I don't understand. That is my first point. And thing is this, removal of normal delivery packages in SGP 2022, which will help the strengthening of the public hospitals, because we need that. The people have to go, people have accessibility to the hospitals, and at the same time, until and unless we develop, we strengthen our public hospitals, the healthcare delivery system will not improve. There are lots of manpower, very less manpower in our state, particularly in the specialist form, and where they have to go for the private hospitals to visit, and out-of-pocket expenditure is another major point, because the practitioners are outsourced in the private hospitals. They are not employed. That's why there is always out-of-pocket expenditure. And in the cesarean case, 12,600 in our state, it was rate. There are lots of cases where we have found that there is 10,000, 15,000, 20,000, 25,000 out-of-pocket expenditure is there. Then can we make some changes that whenever there is the outsourcing of the specialists are there, the hospitals should not be allowed to go for the specialties empanelment in particular sector. Because in that way, there are lots of patients are there. Hospital is also there, but they are not employing the doctors or the paramedical staff in a permanent structure. That's why there is out-of-pocket expenditure. So we can make a rule that whenever there is particularly basic 5 specialties like your general medicine, general surgery, ob-gynae, pediatrics, and anesthesiologist. These 5 specialties should have their own specialist doctors in-house. Otherwise, there will be out-of-pocket expenditure, and very purpose of our scheme will be lost. So that is my point, that I think our specialist committee will consider on those points. And one more point is, we have got high-end investigations, and this high-end medications also included in the SGP 2022, but there are few medications which are left behind. There may be some requirement for surgical package as well as the medical package. So I think there should be a provision in the master that we can go for any other unspecified, unlisted drugs or unlisted investigations which may be included on actual. So these are my points. Thank you very much.
Thank you, sir. Dr. Shankar.
I think we can have one more question and then we'll answer. We had one more question there.
May I request for the mic at the back, please, back of the room?
Good afternoon, everybody. So my question is regarding the slides that were displayed for trastuzumab. As you also presented that the most cost-effective approach is to give a short-term course of trastuzumab, whereas the request that we at the state and also at the NHA we always receive for 14 to 18 cycles, that is a regular thing, more than 10 at least they will always prescribe. How do we, since this has not yet been, this study is not yet reflecting in the treatment guidelines, the standard treatment guidelines, not of the NSA, but not the NHA, maybe the NCG. How do we circumvent this, and how do we motivate our clinicians to, we cannot ask them to prescribe less number of cycles, and conversely, we can't, being the state health agency, we cannot just give for, a part of the cycle, and like this is basically defeating the purpose of the scheme, where our beneficiary has to go in for an out-of-pocket expenditure if we are only giving part of the treatment regime. So how do we circumvent that, or maybe how do we advocate to the clinicians to, prescribe the number of cycles or reduce the doses?
I think both the questions are quite challenging. At the NCG meetings as well, I think there's a long discussion usually to basically identify ways of how to convince clinicians to maybe change their clinical practices based on more efficient
pathways of clinical practice rather than just basing the decisions on clinical effectiveness alone. So I think it's probably going to be a work in progress to make the clinicians change their clinical practices based on these guidelines, because as was being mentioned in perhaps the Dan's talk also in the morning also, that the clinicians generally would like to have the clinically the most effective intervention to be used without any consideration of what the cost is. So I think that's the response that I have. But I'm sure that the Dr. Pramesh might like to add anything if during his talk on the particular issue about how the NCG would like to react on this particular issue. On the first questions from Assam, I think we had a consultation earlier as well on the delivery packages, and we'll be happy to receive your specific state request. We'll consider that issue, because as of now, as per the OM that has been issued, that was the mandate in terms of the distribution, in terms of the utilization and the restriction to the public sector alone. The question on the high-end medication that you had, I think the response is that we initially, while we were introducing high-end medications, at that time also there was also a risk that it may lead to more abuse as well. So there should be very strict monitoring, there should be strict linkage with or mapping with certain procedures where these high-end medications can actually be used, etc., or standard treatment guidelines. In the lunch session, I was having a discussion, and I was being suggested that even for ICU packages, we should have specific guidelines that prevent any kind of an abuse. So the point is that any new thing that we add, there is, or any place where a price is increased, there is also a chance for abuse. So I think it's a gradual journey. We've added a few drugs, we've mapped them against certain packages based on an analysis of the way that the utilization takes place. We can perhaps consider expanding the list of those medications. To keep an open-ended choice perhaps would be a very far-fetched thing because that may be then very, very difficult to subsequently monitor utilization and other things. So that may be quite a challenge then in several states.
Thank you, Dr. Shankar. I know there must be a lot of questions, so I would request you to find the speakers during the tea break and ask them one-to-one. But before we conclude the session, I want to request Dr. Kameshwar Rao, if you can give a memento to Dr. Andres as a token of appreciation for coming all the way on a very long flight to India. Requesting Dr. Ruchira Agarwal to give a token of appreciation to Dr. Shankar. It will happen. That's next. And now I request Dr. Shankar, please, if you can also reciprocate the gesture and give a token of appreciation to Dr. Kameshwar Rao. Dr. Shankar also requesting to please give a memento to Dr. Ruchira Agarwal. Thank you very much. So we'll meet in 15 minutes after the tea break. Please enjoy your break.
Budget is something I enjoy.
I am not an economist. I speak about.
I think all these areas are so important.
criteria to involve the people, I mean to include the people, is different in different states. But many of the states have used common criteria, including the NFSA data or food and civil supply related BPL data and all. But there are few states which have taken even the coverage in a more innovative ways. One of such states is Tamil Nadu. They are the first state in India who thought of covering the population based on the income criteria also. So their first policy was launched with an coverage of minimum 80,000, less than 80,000 income population. So we have the representatives from Tamil Nadu. I request Dr. Shri K.B. Ganesh, who is the Chief Medical Officer of Tamil Nadu Chief Minister's Comprehensive Health Scheme. He has been associated with the Tamil Nadu's Chief Minister scheme from 2012, and he is the Chief Medical Officer from 2016. He is the member of the package committee, I mean health benefit package committee for Tamil Nadu Chief Minister scheme. He is also a consultant for planning committee of universal health coverage. He has played a very vital role in designing and implementation of empanelment criteria with respect to Chief Minister's health scheme in Tamil Nadu. So we welcome you, sir, with wholeheartedly for your presentation, and floor is for you now. Thank you.
Good evening, everyone. So the overview of CMCHIS. CMCHIS was initially started in the year 2009. It was started with an objective of providing access to healthcare for the economically weaker sections in the society. Back then it was decided around 72,000 rupees per annum for the entire family. And then after analyzing the outcome, in a very short while we started to include various unorganized sectors of the population, like construction welfare board members, the tribal groups, and every other people. So during the initial phase between 2009 and 2012, the sum insured was a block of 1 lakh rupees for a block of 4 years, and around 650 life-saving critical care coverage was provided. In 2012, the scheme was revamped with an objective to move towards the universal health coverage. So in 2012, we launched an expanded scheme. In 2017, the focus slightly migrated towards quality of services. I'll explain how we proceeded with that. In 2018, we merged with ABPMJ as with many other states, providing the sum insured being 5 lakh rupees. And in 2022, the scheme was renewed with the focus on health inequity. So this is the slide to overview how many members were covered and all. So in 2017, after seeing around 1.58 crore families being in the system, we entered a process of deduplication. So we removed almost another 20 lakh beneficiaries who are either in the higher income ceiling or they had migrated to different insurance sectors or other people. So they were deduplicated. So how this model works? So this is basically a tax funded scheme, and it has started to protect the underprivileged families from catastrophic health expenditure. So hospitalization payments were a bundled payment system, and we sort of engaging both public and private sector. So hospitals were paid on a value-based payment system, completely paperless system. Again, we provide standalone diagnostics and follow-up services for critical care. So quality was standardized across the providers by asking them to provide only US FDA or CDSCO approved implants and devices. And in 2017, we made mandatory accreditation of NABH, NQAS or JCI or ABPMJ certification in 2018. And we had various audits like mortality and morbidity audits. We continuously revamped the infrastructure requirement of hospitals who had to get empaneled in the system. And we also have a methodology of payment, which is basically a corpus fund generated from the government payments. So this system works for providing more than 5 lakh amount for selected procedures like liver transplantation where we pay up to 22 lakhs, or bone marrow and stem cell transplantation where we pay around 17 lakhs for mud transplants. And we also focus to primary healthcare outreach camps like schemes through preventive health services. And we coordinate with this RBSK program, ensuring children who are underprivileged also get coverage under the CM scheme. So the target beneficiaries presently revamped to an income ceiling of 1,20,000. Orphans are included, labor welfare board members, transgenders, differently abled members without any income ceiling, Sri Lankan refugees, members with psychiatric disorders, all of them are included without ration card or any income ceiling. Members who are identified under SEC database who are not already covered will also be covered. Migrants are either covered under ABPMJY or by the Labor Department. So this is how our packages evolved. In 2009 to 2011, we had around 650 procedures which were mostly tertiary care or emergency and critical life-saving procedures. In 2012, as we said, we were slightly migrating towards UHC, so we include more tertiary care procedures and a few secondary care procedures. In 2012, we deduplicated and merged around 250 packages and included 315 new packages, bringing up the number to 1,027 packages. In 2018, we merged with PMJAY, so therein we identified 423 packages which were not already part of the system and included them as part of our state HBPs. In 2022, we again made a revision of packages where we duplicated and removed a few low performing packages. We included rehabilitation therapies, genetic testing, provision of cochlear accessories, etc. So this is a version of our mapping with ABPMJY wherein we both of them must have a common process of 947 and some 1,000 odd procedures are exclusive in PMJY which we adopt in the state. So present iteration roughly covers 1,090 procedures plus 900 procedure from PMJY. So what do we have in state specific packages? So we cover heart transplantation, lung transplantation, liver transplantation. All these are paid somewhere between 15 to 22 lakhs. Auditory brainstem implantation we provide. Then for the cochlear implantation, all those who have been done already, they don't have any means to get the accessories repaired or serviced. So after analyzing the data for past 3 years, we decided to cover cochlear accessories also under the insurance, wherein the replacements will also be provided within the system. We in addition cover functional prosthetics, orthotics, some chemotherapy regimens which will not be available in SPP. HIPEC we cover, peritoneal dialysis catheter exchange we cover, hepatitis drugs, diagnostic procedures, gender affirmation surgeries, bariatric surgeries, etc. So how frequently we do it? This being a government sector, there is always a tender floated. So during every tender, there is a revision happening. So initial package revision was done in 2012, in 2017, and 2022 was the latest iteration. So how we moved about it? During every revision, there was always a certain objective in the mind, along with addition and deletion. So 2009 was basically life-saving and critical care. From there, in 2012, we wanted to migrate towards UHC, so additional secondary procedures included. But we also wanted to take care of the chronically ill patients who had other modalities of treatments available for them as a cure or as a sort of continuum of care. So we included transplants, we brought in cochlear implantation, we brought in maintenance treatments like hemodialysis, peritoneal dialysis, etc. In 2017, we sort of basically deduplicated, merged similar procedures, and 315 additional procedures included. But we focused on quality. So this time we brought in mandatory quality accreditation of hospitals through NABH, NQAS and all, giving them sufficient time to get themselves accredited. And towards the social side, we were focusing on mental health disorders. Though it was a new arena, we thought of implementing initially 6 procedures, but then restricted ourselves to early intervention for autism spectrum disorders. And towards providing the economic and social independence to the amputees, we sort of provided them functional processes. Unlike our standard prosthetics which were initially part of the scheme, we thought we'll provide them mobilities. So various mobility grade prosthetics were included in the scheme. And in order to accommodate the rapidly developing chemotherapy options in the field of oncology, we thought, let us have an open packaging system. Instead of giving specific packages, we added other regimen as an option, wherein internationally approved chemotherapy regimens can be included at any part of the time by a provider. In 2022, we deduplicated few low performing packages and 86 new packages were included. This time focus was on addressing the health inequity in the context of mental health disorders again, sexual orientation and gender identity, and we brought in rehabilitation services for various disabilities, provided cochlear accessories, we included gender reaffirmation procedures. Further, to address the advancing healthcare, as the genetic disorders are getting predominance across the world, we sort of included genetic testing also in our packages. And to include futuristic delivery models, we tried to trial with palliative care initially actually for delivery of healthcare services at home, wherein we could give the palliative drugs to a patient at home. However, we restricted ourselves initially with peritoneal dialysis. We may replicate this model in the future for other healthcare also. So, how do we revise? What do we do about this? Generally, whenever we plan to do a revision, we inform the hospitals, healthcare providers, our medical associations, every members that the state is planning to do a revision, so they can give their feedbacks and inputs on either existing packages and new provisions to be included. We discuss with the patients on where they had to spend some money or additional expenditures they incur towards travel or whatever. So that could be collected. Then we also discuss with the implant vendors wherein the cost of certain drugs or implants could be brought down. I'll explain this later. And then all this information is put across through a committee of experts, mostly government doctors. So they sit and discuss against each procedure, the pros and cons, outcomes, everything will be discussed in detail before it is passed on to the ratification committee. So this is how it works. Whenever a set of packages is given, let it be even from a government doctor or private doctors, they give you a very expansive list of procedures. So we have to always analyze them based on certain parameters. So what we include is expected disease burden, whether the technology or the procedure is life-saving or it is very critical care procedure, whether it will avoid catastrophic health expenditure to the family or it has social impact like productivity of the amputated patients, economic and functionality. So then we assess them whether the specific procedure is available across the state or whether it is limited to specific hospitals. And we also explore the existing packages, whether there is an alternative available. Then existing packages are also modified based on whether we can provide better outcomes in the procedure by making certain modifications or not. Can we reduce hospital stay? So in some open procedures may be converted into laparoscopic procedures also. Then we take the feedback from patients for out-of-pocket expenditure. Then the scope of existing packages, like how we change. Basically, we had a specific package for excision of tumors for cancers. Then we simply removed the for cancers part and removed it, made it as any type, which includes now laparoscopic, open, even for benign conditions. So such modifications happen. Then fixing of package, this is where it gets a bit complicated. Generally, being mass health insurance, we cannot provide a fee for service model. So definitely we have to assess various expenditures. So while we assess the capital cost, generally speaking, such models cannot provide the entire cost of the hospital. What we aim to provide is the hospital is always in a no loss. That is the only thing we can always aim for. But with obviously with increased volume, they can make some profit. So the packages are always designed based on bed charges in general ward, ICU charges, post-op ICU or specific ICU packages if there are any, operative charges, diagnostic tests, medicines, devices and consumables, nursing charges, food for the patient, post-operative investigations if needed, then medicines up to 5 or 7 days depending on the package, minimal transport expenses. So while we design this, as we know, many of the implants and drugs, the maximum retail price will be exorbitant. And when we design the packages, if you are going to provide the same rate, it is not going to be affordable. So we discuss not only with the hospitals, but we bring in the vendors of suppliers of manufacturers or various members for specific implants. Say for example, even before the NPPA capped the cost of stenting, we had brought in imported stents to the cost of 22,000 and indigenous stents somewhere between 14 to 17,000. So this was done even before NPPA had conceptualized the idea. So similarly for trastuzumab, as an example, sir had earlier said, when we brought in trastuzumab in 2017-18, the cost of the drug was around 40,000 or something. We had negotiated with the vendor for 17,000 rupees, and we were able to provide complete 18 cycles initially before the FinHER trial had taken place. So such factors are also brought in. Then package rates are finalized. After that, we evaluate whether they provide us a better treatment outcome, expected package rate, whether such a package rate is viable to the healthcare providers, because this is very important, otherwise there will be money collection. Then the cost benefit ratio, if I bring in a package, whether it will be helpful to the patients and whether it is economically suitable for the budget. Then abuse potential is also analyzed while bringing in the package. Then based on the analysis, we reserve certain packages to the government hospitals also. All these decisions are then proposed to the state empowered committee. As we said, the final modifications will be based on the final budgetary allocation made by the government. So what do we look for? Proceeding more effectively towards UHC by 2030. We are also looking at constant changes in pricing, capping of various drugs and consumables. We look for various innovations in the field. So like mechanical thrombectomy, we are going to bring in by this year. Then integration of primary care in conjunction with the scheme. We will not be paying for this, but we try to integrate them. So the state is also looking forward towards preventive healthcare model. This is very important. We are treating NCDs. We are now only paying for the diseases. We should conceptualize towards preventing a disease. Therein the costs are decreased immensely. And we also look for continuous learning from various states and ABPMJ and international healthcare providers. Thank you. If there are any questions. Thank you.
So we'll be having the last session of the day today, which is a panel where we'll have national and sub-national experiences shared on how analytical methods have been used to update health benefit package. So I want to request Dr. Peter Baker, if you could please come on the dais, as well as Dr. 𝑐𝒑𝒕𝒊𝒏𝒈. From Malaysia, we have Izani Mohammed Razif, and from Ethiopia, we have Alimayu Hailu. If you can please come on the dais. I'll just introduce the moderator of the session. So Dr. Peter Baker is an assistant director at the Center for Global Development. He's a public health physician and is currently a member of the Technical Appraisal Committee of NICE UK. He does a lot of work on priority setting and HTA in Africa. So handing it over to you, Dr. Peter, to introduce the rest of the panelists.
Just checking this mic is working. Great, wonderful. Thanks, Abba. I'm delighted to be moderating this final session of the day, the final panel of the day. So we will be looking at a range of organizations. We'll be looking at both national and sub-national efforts to use analysis for health benefit packages, both in the India context and in Malaysia and Ethiopia. So to my left, we have Dr. Alimayu Hailu, both from Ethiopia, an advisor to the Ethiopian Ministry of Health, but also from the Bergen Center for Ethics and Priority Setting. And then to my far left, we've got Isni, who you just heard, from the Ministry of Health in Malaysia. To my right, Dr. Pramesh, from both the Tata Memorial Cancer Center and also the National Cancer Grid. And of course, you just heard 𝒔 from Tamil Nadu SHA. So we have a slightly limited time today, so I'm going to try and focus we have 4 questions for the panelists, and I'm going to try and focus a little bit, if that's okay, to the panelists. So can I start with my colleagues on the left? So Alemayo, what I would like you and Isni to look at is to describe in your context, in your countries, can you provide some examples of how you've used analytical methods to support benefit package design, and perhaps how that was received by policymakers? So, Alemayo.
Thank you, Pete, and good afternoon all. And I think this is very important question. But first of all, let me say thank you for Joint Learning Network for bringing me here. And I learned a lot from yesterday and today also. And I also would like to congratulate the team working on the health benefit package design in India. You have done really very meticulous and very critical work, and yeah, this is really important work, and you have done a lot of analytical work. And in Ethiopia, just to give you some highlight about the essential health service package in Ethiopia, the revision was done from July 2018, and at the beginning it took 1.5 years, almost 2 years. But at the beginning we were given 2 months to accomplish the whole revision work. It was the instruction from the minister to finish before the Ethiopian New Year in September. The assignment was given to us in June, July, and it was to be done by September. And we had no chance to go into very detailed analytic work within that very short period of time. But then what we did was we prepare a roadmap, including what kinds of analytic methods we need to use. Then we share the roadmap with WHO team in headquarters, country office, regional office, and also we share the roadmap also with different partners and also academics in Bergen, in Norway, in US, to Harvard, and so on. Then they gave us very critical feedback, and we present that to the minister, and we have got enough time to go into detailed analytic work. So the analytic work we have done was, we have start from burden of disease analysis. We review the country level data on burden of disease, and also we use the global burden of disease. We also used cost effectiveness analysis, and we used the WHO generalized cost effectiveness analysis tool. We have got a cost effectiveness ratio for around 200 different interventions on different disease group. We also have done literature search, and we use also cost effectiveness from other sources. And also we have done budget impact analysis. We estimate cost, and also we also have done physical space analysis, and we also try to compare the gap, how much additional resource is required. And yeah, these are the analysis work we have done in the benefit package revision. But yeah, I really, when I compare what we did with what I see here, you have really done very meticulous work, including very detailed analysis, and I want to congratulate the technical team again.
Thanks, Alemayo. I think you're being very modest. I think Ethiopia has done some very impressive work using global evidence, like you say, in a very short amount of time to design a benefit package in a context with limited data, and it's all available in peer-reviewed articles for people to take a look at. It's quite impressive. Thank you. So, Isni, over to you and the perspective from Malaysia.
All right. Okay, is it working?
Okay. Thank you, Peter. Thank you to the organizer. I'm so happy to be here to listen to all the experts' opinion and the hard work that India has done. It's so amazing. In Malaysia, just a little bit of background about Malaysia, we have a dual system, public and private sectors. And it's about equal expenditure, slightly more on the public sector. And we don't really have an explicit benefits package. We are more into implicit benefits package and carry on the historical services that has been provided by the public sector. But we do have the health technology assessment in the sense that when they are reviewing the existing technology or they have a new technology coming in, and there is a request from the clinicians to see the cost effectiveness, the safety, the efficacy of the technology. They will do the request to the health technology assessment unit. Is under Ministry of Health. So the unit will do all the technical analysis, and they will present it to the Director General of Health, also in the Ministry of Health Malaysia. And if they want to include that technology into the services provided by the public sector, the Ministry of Health need to provide a justification to request a budget from Ministry of Finance. We call it a new policy budget. So this is is a very line item based kind of thing. So we request that budget from Ministry of Finance, and these few months we have seen a positive feedback from the Ministry of Finance when we use data to justify our budget requests. So other than that, we have also another department in the pharmacy division where they look at the new drugs that they want to include in. So this, under the pharmacy division, the compulsory requirement is for them to do the budget impact analysis. So this is the compulsory thing. But before they even request for inclusion into the formulary, they have to pass all the safety, all the registration of the drugs in Malaysia. Then only they can request to include that in public sector. So in this year, I think because of the change of leaders in finance ministry and also in health ministry, we have seen that how data can help us in getting a new budget for the new technology and drugs.
Thank you very much, Isni. I think it's an important issue you raised around how carrying out the good analysis can actually help you with the negotiation with the Ministry of Finance and actually help you to support making the case for additional resources. Okay, so Dr. Pramesh and 𝒑𝒂𝒃. 𝒑𝒂𝒃, you've already talked about the methods that were used in Tamil Nadu, so perhaps there's no need to go into more detail there. But I would be interested to know, when you engage with policymakers with these results, how did they respond? How did they take the analysis? And would you now, in future, think of doing any additional analysis that might be taken up better by policymakers? So over to you in a second, but then, so you first, but then Dr. Pramesh, we haven't heard about your work for the National Cancer Grid, so it would be great to hear what methods you've used and also how you engage policymakers and how they take your findings.
Thanks, Pete, and thank you to the organizers for inviting me. It's been a fascinating morning and afternoon session. I've personally learned a lot. So I don't want to be repetitive about some of the analytics work that fed into some of these packages. So I'll just focus on two main areas which probably haven't been addressed in detail before. Shankar did allude to our costing contribution. But this was actually fortuitous because the Tata Memorial was revising their schedule of charges, which we do frequently. And coincidentally, this happened just a few months before the NHA approached us with whether we had any scientific ways of costing this. So we went into a fairly elaborate exercise which lasted close to a year about costing every single effort that was put into which went into patient care. And we were able to not do a very direct analysis of every single procedure that was done, but as Shankar mentioned, the average number of days that involved inpatient care, the total number of operative time that was involved, and we were able to make some assumptions which led to a fairly rapid way of costing, which otherwise would have probably taken us much more time. So it was fortunate that this exercise happened, and very soon when the NHA approached us about whether we had a ready-made system of doing this, we were able to give them all the data that fed into this. And fortunately, because the raw data of the assumptions was available with us, they were able to make modifications to those assumptions based on a more national need. The second part I want to speak to about is the guidelines for care that we introduced. And while, again, this was not directly related to the NHA, because the NCG guidelines preceded the creation of the ABPMJ packages by almost 2 or 3 years, the second edition was a resource-stratified guidelines, which we divided into essential, optimal, and optional guidelines. And again, fortuitously, the then Deputy CEO of the ABPMJ was present at the National Cancer Grid annual meeting when we released these resource-stratified guidelines, where we described the rigor with which these guidelines were developed, and he immediately signed on to adopting the essential and the optimal packages as part of the reimbursement packages. And again, what went into that at that point was more clinicians' judgment on whether something was cost-effective and not a real cost-effectiveness analysis. But as we were developing those, we realized the benefits of doing a slightly more scientific way of doing this. And while we still don't have the bandwidth of doing full HTAs for every single intervention that's introduced within the NCG resource-stratified guidelines, we've been doing adaptive HTA mechanisms for the last close to a year and a half. We've evaluated 10 fairly important interventions in cancer, which has then guided the NHA on whether they needed to be included or not. So we're very fortunate that we have the support of the NHA and their blessings, if you might want to call it, to support the efforts that we are making towards these adaptive HTA models. We are also in the process of building capacity within the National Cancer Grid for more individuals, more centers to participate in adaptive HTA, because what we've been able to do as a small group is just 10 interventions over 18 months, and we want to scale this up to as many interventions as possible so that they are, so our inclusion into the resource stratified guidelines are more scientific than they currently are.
Great. That was really nice to hear about that partnership with NCG and NHA and how that's working very, very effectively to take up evidence. So Ganesh, over to you.
So as with any government-sponsored health insurance scheme or government-sponsored systems, there is always a budgetary constraint on the government. So whenever we proposed a set of packages, we had to justify the reasons for inclusion. And like Andreas had earlier pointed out, it is very clear that it need not always be the cost which is a driving factor. It can be social causes. Like when we provided for amputation, we suggested functional prosthesis just out of the blue. We had very few indicators, but then we had global experiences showcasing various athletes participating in Paralympics and other things. We had to convince the government to a certain extent that if we can provide this with good quality, then the economic productivity will actually increase. So similarly, while including mental health disorders, as I told earlier, there was a lot of apprehension because of the greater ambiguity to misuse the process. So what we did is we had a discussion with various centers that had been treating, including autism treating centers, and we thought of bringing in early intervention as a first step to look into mental health disorders. So once again, we had to convince the government the potential, how we can rehabilitate these children with the primary objective of social integration once again. So we had taken experiences from various countries, and within the state some exceptional institutions, we had to adopt the guidelines from them. So this always, when the data backs us up, I think the government was always supportive. So this is another example.
Excellent. And thank you also for pointing out the other factors beyond cost and health that so often need to be considered when making these decisions. So my next question is to everyone, but we'll start on my left side. Did you have experience of other stakeholders seeing the analysis and seeing the reports? So I'm thinking, I don't know, perhaps the medical profession or health service providers or So I guess the first question is sort of how transparent was the analysis and the results, and did others see the documents, and how did they take it?
Yeah, thank you, Pete. It's a very important question again. In terms of the process, we try to be transparent, open, and inclusive as much as possible, starting from organizing the team at the beginning, and also in the revision we had conduct around 35 workshops. And in each and every workshop, we try to invite stakeholders from all groups, but there are also specific workshops targeting like patient or disease-specific group or academicians or clinicians. And for example, in the intervention listing workshop, we have involved more than 85, I think, stakeholders. So as much as possible, we also include health extension workers, nurses, physicians at the primary health care, and also doctors, specialists, clinicians, public health experts working in the tertiary hospital and in the university were involved. So input from different stakeholders were used, and we try to make the process fair, transparent, and inclusive as much as possible. But when after we launch the report also, we receive, we try to receive feedback in all the process, but still there are, feedbacks, positive, some complaint, even after the report is launched. I think this is not unique to our setting. Yeah.
Thank you. And I guess that comes to the key point, really. We heard it earlier from Dr. Shankar in many ways that there's always going to be some kind of rationing, some people that are unhappy with whatever decision you make. So you will always get some negative feedback, I guess. But it's part of the inclusive process that you see. It sounds like you did well to consult many voices during your process. So, Isni, over to you.
Okay, since in Malaysia we don't really use the HTA to do some revision of the benefits package, rather than we use the HTA to update the clinical practice guideline. So it's not directly engaged with the clinicians, all the clinicians, to look at the HTA, but when they do the revision of the CPG, they will involve all the clinicians, the providers, and HTA in Ministry of Health also receive requests from the private providers to do some of the revision, and also private health insurance company, because they want to see whether they can include in their benefits package or not. But the revision of external requests is based on the priority, because HTA is not a big unit in Ministry of Health. So the involvement of stakeholders, I would say most of the time providers in Ministry of Health. And then when it went up for the budget request, then only we involve the Finance Ministry. On the drug side, the request can be directly from the manufacturers, but for the devices or procedures, always from the clinicians, providers, or the private health insurance, never from the manufacturers. But the documentation, most of the time they made it available, unless at certain points they are not allowed to publish, but most of the time they do publish what they did, they shared in their website. For drug formulary, they have to go into quite a different process. They have to, when they do the revision, they have to engage with the technical expert committee, also within MOH, before they can include into the formulary. The engagement is not very well structured, but they have a certain committee with the involvement of the providers and the external parties.
Excellent, thank you. And Dr. Pramesh, cancer is always a very political issue. It certainly is in the UK as well. how did you find stakeholders, the media, clinicians, how have people responded to your analysis?
So I think the variability you get in the answers between the three of us will be a testimony to this fact that this is an extremely complex situation here. And if you look at all the stakeholders, you have on one hand the clinicians, you have the patients, you have policymakers, the bureaucrats, and you have industry hovering over all of this, trying to influence what decisions are made. So it's understandable, and I completely understand how patients would want every single intervention, regardless of cost, to be included in these packages. It's their lives at stake. And I think it comes back to a question that was raised this morning. How can you put a price on a human life? And that's a very emotive question to answer, loaded with a lot of overtones, and it's not something that you can respond to purely based on science. With the policymakers, and to be honest, I've found the policymakers the most easy to convince, provided you show them the data. Industry will game the system to a situation where they want their products included into this, so let's leave them aside for the time being. But the biggest challenge is with the clinicians. So I think most doctors took up medicine because they didn't pass high school maths, and to them to try and understand cost effectiveness, ratios, thresholds is probably asking for too much. But one approach we've really found very helpful, actually two approaches. It's one to keep hammering on it till the message goes through. And very often the examples we use are not related to the specialty the clinician practices. So often we would use, do you really think robotic surgery is cost effective, and use this argument to a medical oncologist? And use the argument, do you really think these new fancy molecules like immunotherapy and CAR-T are actually cost effective? When you ask that question to the surgical oncologist, suddenly their perspective changes. They're able to understand this much better, because if I do robotic surgery and you were to question the reason of my existence, I would come up with the reason which is probably not based on science. So I think it's a lot of understanding of human behavior and responses which goes into this, but there's really no easy answer to how you can influence the various stakeholders with this.
Yeah, thank you. From my experience of working with other countries, it's often the medical profession that is very challenging stakeholder here, because I haven't heard it being accused about high school maths before. Perhaps you're allowed to say that in your background. But of course, they are defending the interests of their livelihoods and their professions and what they care passionately about, of course. One argument we've used frequently is to say it's not about costs. It's more about, if you can't do this surgery, if you want to do this surgery, then you can't do that surgery. So it's about trading off between different health outcomes, and you don't even need to talk about money then. But
very often that argument doesn't work, because the need is, let's do both. So they never understand the concept of opportunity cost. So as many people have expressed before, how can you put, the moment you ask, how can you put a price on human life, the answer then becomes, let's do everything, rather than be rational about what we choose.
Okay, Shri Ganesh, is there any additional points beyond your presentation you'd like to comment on this issue of other stakeholders beyond policymakers and how they responded to your work?
Just to pinpoint, the stakeholders does not always mean the clinicians or the drugs and providers. We should always engage with the patient welfare group. Say, for example, we brought in rehabilitation, we had discussed with the Spinal Atrophy Association, Muscular Dystrophy Association, where they had experiences with palliative care of these patients. They are not curable diseases, definitely. So we had a lot of discussion with them. We saw what we could provide in terms of rehabilitation. And always when we had to project to the discussion committee, what happens is everyone looks at outcome. Not everything is based on end outcome. Sometimes we have to put the process in place. For someone suffering with a debilitating disease, just to help them breathe properly is a big step, and that is a big increase. So it's always to put in perspective how we engage various stakeholders, and we also have to be very clear. Not every suggestion given by everyone is going to be taken up. We had this time 2,000 odd suggestions coming up. So we had to be very clear with them also that we are not going to, like Sir had said, our government hospital has a robotic system invested. They put some 20 crores or 30 crores, whatever. So now they wanted to increase this into the health HBP, and they were asking for an appendectomy, some 1.5 lakh or 2 lakh because of cost of consumables. So these are not going to come into the system. We have to be very, very clear. If you can do this laparoscopically, it is better. We don't want you to engage on exorbitant costs. So when you are clear with the stakeholders, even the suggestions that is coming into the system will be very, very clear. So this is what we want to add.
Thank you. I'm afraid we're actually out of time now. It's 5:30. I think what I've heard today, or from this brief panel, is that rigorous analytical methods are often very attractive by policymakers, particularly from those from a health financing background, like Ministry of Finance, will often really appreciate and value the rigor of the methods that are done. That, of course, you often don't have very much time to do some quite complex analysis, and so shortcuts and use of global evidence can really help speed things up. That it's valuable to do some additional analysis about maybe non-cost things, about social factors, about equity. There are lots of other arguments policymakers will need to do, and that other stakeholders need to be brought along with you, such as particularly often the medical profession and other professions can be quite challenging, providers and so on, and I think there's a lot more to be said about how countries have done that. But thank you to the speakers. We've heard from the national level, from one state, from Ethiopia and Malaysia. But can we get a round of applause for the speakers, please?
Thank you very much, Dr. Peter and all the panelists. I want to request Dr. Shankar and Dr. Sudha, if you can please come and give a token of appreciation to all the panelists and the moderator. Dr. Shankar, requesting, maybe we could start from the left, requesting if you can please give a token of appreciation to Izani Mohammed Razif. A big round of applause, please. Dr. Sudha. Request if you could please give a token of appreciation to Alimayu Hailu. Dr. Shankar, request to please give to Dr. Peter Baker. Dr. Sudha requesting to please give to Dr. Pramesh. And last but not the least, Dr. Shankar, please if you could give to Dr. Shri Ganesh. So, thank you everyone. Thank you for being very patient with us and with us throughout the day. We will be meeting again tomorrow at 9 o'clock. So have a great evening in Delhi and hope you enjoy your dinner and look forward to seeing you tomorrow morning. Thank you.